All right, now, yeah, is that all you want me to do is stop it and start it?
That's it.
All right.
Thank you.
All right, I'm gonna admit everyone, folks.
Hey, Matt, I just wanted to give you a heads up. I may have to jump off for a minute just because I am in line for my vaccine right now.
Oh, fantastic.
I know.
Yeah, yeah, absolutely. Well, welcome everyone to our Wednesday, December 16th, regularly scheduled MDPB meeting. It's great to see everyone. I'm going to, if folks don't mind, give a few minutes to our MDPB members who are logging in right now. I know that two of them indeed are doing that because they're in the offices across the hall from me. If you guys don't mind, we'll get them on board and go from there. And while we're doing that, I'm just going to make sure I've got a good list of attendance list here for us.
Good morning.
Morning. All right. Let's see. I know Ray is literally across the hall from me, and she's I know logging on right now. So let's give her a second to log on, and then we'll get going after that. There we go. All right. Well, welcome everyone again to our December 16th regularly scheduled MDPB meeting. It's great to see everyone. Please know this meeting is being recorded. It will be posted on YouTube. Maine EMS has begun recording meetings recently in an effort to allow folks who can't attend at this time to still keep in touch and keep aware of what's going on and listen in on this conversation. As an MDPB member, please, if there's background noise in your environment, turn down your mic or turn off your mic, but speak up if you have a point that you want to raise. For guests, if you don't mind doing the same and use the chat function or the raise hand function. We want to hear from everyone, but just in the effort of keeping the meeting logistically running smoothly, if you don't mind doing that, that'd be very, very helpful. I'm going to run down our list of members and make sure that I am keeping an accurate account of who's attending right now. And as other members arrive, I'll make sure to mark them as present as well. But so far I'm seeing certainly myself, Kate, Mike, Seth, Tim, Dave, Beth, Benji, Kelly, Bethany, Claire, and Ray. Am I missing any of our MDPB members who joined and entered that I didn't see? All right. Hearing none, why don't we get started, and we will bring our other members in as they arrive. I want to start, why don't we just actually start with introductions and have our MDPB members introduce themselves to the audience in case there's someone who doesn't know who you are. I will begin. My name is Matthew Scholl, and I am the Maine EMS Medical Director. Kate, do you want to go next?
Yep, Kate Zimmerman, the Associate Medical Director. And Matt, if you want to make me co-host, I can help you.
Thank you. I'll just call out your name if you don't mind introducing yourself. Mike?
Mike Bohansky, Region 1 Medical Director.
Seth?
Seth Ritter, Region 2, Tri-County.
Tim,
Tim Pay, Region 3.
Dave,
Dave Sakay, Region 4.
Beth,
Beth Collmore, Region 5, Aroostook EMS.
Benji,
Benji Lowry, Region 6, Midcoast.
Kelly, I know that Kelly is standing in line to be vaccinated against the coronavirus. So she mentioned she may phase in and phase out. We'll get her on board when she gets back. Bethany,
Bethany Nash, pharmacy representative.
Pete, welcome.
Morning, Pete Tilney, at large.
Claire, I hope you're staying warm.
Trying to get the firewood inside, but Claire, ALS representative.
I don't see our BLS rep, Adam Thacker, but I'll keep an eye open for him if he joins us. And then that brings us to Ray. I think you're muted right now, Ray. I can hear you from the office, but I can't hear you on Zoom. Is everyone else?
It comes through the walls.
It comes through the walls. Are you able to hear it all, Mike, on Zoom or just through the walls?
No, her mic's not picking up.
Well, welcome everyone, and welcome to all our guests. We really appreciate you. We all really appreciate you being here and being present as we have this meeting. I need to apologize to the MDPB because while Chris very dutifully got minutes to me, I got into a little bit of a black hole with our vaccine work and didn't get them to you, and I apologize for that. We will bring those minutes to you in our January meeting. And again, that fell on me. Chris did a fantastic job getting those minutes to me and Kate, and I didn't get a chance to review them and send them out to you. So again, I apologize. That brings us to our state update. Sam, I saw you on the phone or on the Zoom room. Would you like to provide any state updates at this point in time?
Good morning. Thank you, Matt. So I hope everyone's doing well. I am immensely grateful for all of the hard work that you can continue to do. I know many of you have been contacted and are actively working on mass vaccination projects that are going on in each of your respective municipalities. And so that is something we are working on. I am excited to say that we have placed orders for the vaccine. So we have placed an order to vaccinate the number of people that we know are affiliated with services. So we have all of that vaccine has been ordered for the state of Maine. Additional folks like, say, people, Maine EMS office staff who don't work for an agency but hold a license, those numbers, we still have the capacity to request vaccine for those numbers. But we have requested it for all the persons who are affiliated with an agency. So that is extremely exciting. We have received applications from over 20 sites that will be administering the vaccine. There are still some agencies that have not submitted their application. It is important that if you are a medical director for one of those agencies and they have asked you to sign an application, that you assist them as quickly as possible, as they will not be able to receive vaccine until that application is submitted and accepted by Maine and US CDC. They just can't receive an allocation until that's done. So just letting you know that that is something that we are working on. I know that Chris from my office is working furiously to make sure that the education is built out. And so we hope to have that out late this week or first thing next week. So that is kind of in the works. As far as other projects, I know Matt will talk about ET3, but we have been working on that extensively lately. So those are other projects that Maine EMS has been working on. As far as other major updates, we do have legislation pending that will be going to the 130th legislature, and that will be for outcome level data. The same bill that we submitted previously, we resubmitted for consideration. And so it had been voted out of the committee as ought to pass as amended. However, back in March, it just didn't get heard on the floor when they were hearing bills that last day they were in session, which was, I think, March 17th. They just didn't hear that bill. And so we hope to get that bill heard and get that bill passed as quickly as possible. Please note that there are rulemaking processes associated with that. And so we won't have the data instantly. We will need to do some rulemaking. However, unlike this previous rulemaking process, this will be a single section and it will be a very isolated set of rules. So that hopefully will kind of smooth out that process and make it a little bit easier. Talking about rules, the rules were approved by the board and put forth to the Attorney General's office for review. They have to do a final review for legality and to make sure that we're not violating the Maine Constitution or something silly with one of the rules that we put forth. But as soon as that is reviewed and approved, those rules will go into effect. I imagine that it will be sometime in January or at the latest early February. But those rules are coming down the pike and they've been approved on our side. So just letting you know that that is coming and those changes will be coming down the pike in the immediate future. Though I believe that's all I have for Maine EMS. I am immensely grateful for everyone's commitment to the forums and making sure that EMS clinicians and other public safety professionals are well informed when making the decision as to whether or not they would like to receive the vaccine. If any of you have pictures of you getting the vaccine, we would love to have those photos because we will be posting those on our Facebook page and our Twitter feed to basically show that we're not just saying go do it, we're doing it. And so we would love to be able to post that if you have a photo of you getting the vaccine because that's really important so that people know that we're practicing what we're preaching here. I think that's about it. Thank you, Matt.
Thank you, Sam. Any questions for Sam? All right, hearing none, why don't we move on? The next items on our agenda are our standing items surrounding special circumstances protocols and new devices, of which we've had none presented to the MDPB. So we'll move on to the next item, which is the update around medication shortages. And it strikes me, Bethany, this might be a good time to discuss the email and messaging that you sent out yesterday, and I can bring that up on the screen for everyone as well. Give me 1 second and I'll pull that up.
Sure, I can talk about the drug shortages while you do that. So the most recent one that I've been hearing about is glucagon, of all things. The brand name is currently available, but it's about $60 more than the $100 generic. So that may become an issue at some point. As far as I can tell, the magnesium sulfate shortage has all but resolved. There may be a couple patchy difficulties getting it, but it should be back in stock. As far as I know, those are the only things I've been keeping an eye on.
Bethany, can you say again what the difference in cost between the generic and the name brand is?
Of the glucagon?
Yeah.
$109 is the generic for the 1 milligram vial, and then I think she said 59 for the brand name. So it's about a third to 2/3 more. But I don't know exactly where that shortage will affect EMS since we don't use glucagon all that much. So it may not actually hit the trucks, but it's just something to be aware about. And as far as this nitroglycerin, so since we started talking about aerosol generating procedures with COVID in the last month or two, the issue of sublingual nitro came up. A lot of services use the nitro spray as opposed to the tablets, and whether this formulation was available to be used as a multi-patient device. I've gotten lots of inquiries about it and how it would be easy to wipe down and be able to use per, just use a stock bottle for multiple patients, which is the traditional use of nitroglycerin, oftentimes aspirin, our newer edition of acetaminophen, all come in bulk bottles and are used for multiple patients. So I came up with a couple of comments. This one that Matt has up on the screen is what we might decide on if we decide to discourage the practice of using these bulk bottles for multiple patients, in line with accrediting bodies like the Joint Commission and the manufacturer's intentions of not using their bulk bottles on multiple patients. I had a statement prior to this that, I don't know if Matt, you have that one too, but it discusses the availability to, if you're being careful in swapping gloves or wiping down the spray bottle after use, that it may be used for multiple patients. I think we've kind of, from talking about this, decided that the nitro spray is not an aerosol generating procedure, but that's not exactly my area of expertise. So I thought I would bring this back to the group and see what everybody thought.
So yeah, thank you for that, Bethany. So this came up in context of whether using nitro spray is an AGP, but then we realized that we are using those devices on multiple patients and wondering if that is legitimate practice at this point in time. And
as you can see, it's a picture of a car and a vehicle crash.
If you're just joined, can you place yourself on mute? There's a TV show going on in the background. Again, the question arose whether we can use these on multiple patients. And while there was the first position paper that Bethany nicely wrote out, in the background behind the scenes was, I think there was legitimate concerns that we were condoning a practice that's not condoned in any other place in the healthcare system, and whether or not we can actually do that. And so that's the genesis of this, which dissuades the practice of using those devices, either the spray on multiple patients or the bottle of nitro on multiple patients. And just, Bethany, to help further inform the MDPB, can you remind us again of the cost of those two devices? Because I do believe the costs are part of the issue here.
Yeah, so the tablets, a bottle of 25 is about $6.70. There is a unit dose powder that's available, but that's one dose per packet. That is $6.80 per dose. So in order to meet the 3-dose requirement or potential 3-dose requirement for a patient, you'd have to triple that. And the nitro spray, I believe Rick Petrie had the most updated price, is about $130. So using that one per patient probably would not be something that the services would want to do.
But the small tab vials that are in the opaque vial are $6.70 per vial. Is that correct? Yeah,
that's correct. And it was suggested that we have unit dosed products from the pharmacies be available, but the way nitro is formulated, it needs to be stored in glass, and packaging them unit dose is virtually impossible. So the 25 bottle is pretty much the only way we can go.
So is there any discussion amongst the members? Essentially what this new draft does is it really does dissuade the use of either a spray or a vial on multiple patients, and it suggests the use on single patients. Any discussion from the group? Any thoughts about that?
Hey, Matt, it's Benji. I would just be interested in hearing comment if we have any representatives from agencies on the line, or if we have any data about how much typical agencies are using, just to figure out the economic impact. And we know the cost of the vials. The question is how many would this, or how much would this change what they're doing, and how much would it cost? And I'd be interested in hearing that comment.
Yeah, if anyone wants to speak up, raise your hand, please. And while folks are considering that, Benji, I'm going to just pull up our 2018 data set that Mark Minkler put together for us, which lists all of our medications. And that lists medications and procedures nicely. And it looks like nitroglycerin, my recollection is nitro is one of the more common medications that we use. But let me confirm that recollection. So we used it 8,696 times, which is less than oxygen, saline, and fentanyl, but it is the next most we use on Dancitron more than nitro, but it is one of the top 5 medications that we used. Joanne, would you like to speak up too? Let me see.
Yes, we've been using all medications as single dose for many, many, many years in Tri-County. And the nitro spray is very popular and is, very useful in certain types of, patients. And and we're able to get it at a very reduced cost. I think it's somewhere between $18 sometimes and $26 per bottle. It's on what I think is called the 340 list, and our pharmacies are able to provide it. We've been using it as single dose, and I have checked with all of our services. That's what we have been we've been doing. Without a problem. So it would be detrimental to, I think, remove it. I think, as an option for folks, but maybe people could explore being able to get it at a much more reduced price.
So the issue with the 340B is that the hospital has to be a part of that. Midcoast, we are not 340B, Maine Med is, CMMC is. So it depends on the purchasing pharmacy as to what the prices are allowed to be. And there is no intermingling, if you will, of drugs that are on the 340B list. So I couldn't borrow nitro spray from CMMC and give it to our EMS services at a reduced cost. It would be illegal.
So you're saying take all the chest pains that use nitro to Maine Med?
Yeah.
It would be
that
interesting
Joanne
to know which hospitals were 340B and how widespread that was, because my understanding is, and Bethany, I'm sure you'll help me clarify this, that's a drug purchasing program for hospitals that generally serve underserved areas. It doesn't necessarily match up perfectly with like critical access, but same idea.
Yeah, it depends on the proportion of patients that receive federal or state insurance and are paid that way. So in the Brunswick area at Midcoast, we don't have enough of those patients to qualify for 340B.
Chip, thank you for raising your hand. Do you want to speak up too? Chip, I think you're muted right now. Chip, I think you're muted, unfortunately. Can you unmute yourself?
How about now? Can you hear me?
Yeah, we got you now. Thanks.
Thanks. Sorry, no, this computer decides to like to pick its own microphone. I get the discussion, I really do. Certainly, I understand that this is something that is, unheard of in any other part of the House of Medicine, but I guess I would have to suggest that our practice is unlike anything else in the House of Medicine. We go through a lot of nitro. We do 19,000 calls a year. About 9,000 of those are 911 calls. I can run a med log and get you an exact number of administrations, but it's gonna be a big number. This is gonna be tens of thousands of dollars just at Delta if we throw away the spray after every patient. Tabs, I'm told, are costing us about $30 a bottle, and nitro spray is 130. We switched to the spray for a lot of good reasons that I think we're patient centric, and ultimately it's you guys' call, but there's big money on the table here.
Yeah, it's unfortunate. I'm not suggesting that we get rid of the spray altogether. I want to leave whatever option services choose to go with. And honestly, I wish nobody had asked this question, because it would have been nice not to have to address it at all, especially formally in this kind of way, because of the reasons you're mentioning, Chip. But it's hard to, especially as a pharmacist, not follow the rules as far as legality and the manufacturers and the accrediting bodies go. So I am completely torn on this one, but that's why I brought it back to the group.
So we need to make a decision. Is there any other discussion before we get there, though?
Do we know if there are other EMS organizations in the country that perhaps have advocated with some data or some sort of support that it is okay to have multi-use? I mean, anything to back us up and say this is why we are willing to say it's okay.
I did a quick search yesterday because I had that same question to see if there was a precedent here. And the only couple things that I found in line with multiple patient use was that it was prohibited in a lot of EMS agencies and services. New Mexico was the one that came up first, but they specifically called out multiple patient use bottles of medication and said it was prohibited.
Guys, I have a question about the last two lines here about leaving a medication with a patient. Obviously, if we were leaving a patient at home, we don't want to leave a medication with a patient, but I'm just thinking in terms of, other medications that may have additional use inside the hospital, especially at the time that we have a pandemic, like an albuterol MDI, which I know not a lot of agencies are carrying, but I'm just thinking about these two lines and extending that beyond just the nitroglycerin spray.
The reason I brought that up is because one of the emails I received was referenced leaving medication with patients, and I kind of wanted to point out that that is not in the scope of practice. Even if the patient has a prescription for medication, they're not allowed to dispense nitro or aspirin or anything along those lines. I'd be happy to reword that. I was just kind of throwing it in as a reminder that if we do state that we can't use these bottles on multiple patients, they are not to be left with the patient. They need to be disposed of.
Bethany, what if the paramedic left it with the patient's nurse to dispose of?
I feel like using monkey emojis right now with the hear no evil, see no evil, speak no evil. There are a lot of things that I struggle with as a pharmacist, having been an EMS provider. So when I am asked these questions, I have to give the appropriate answer. So I don't think that's okay either.
Yes. I
You also
feel like
have
it's a
to-
medication that needs to be disposed of appropriately, and the nurses know the hospital procedures, so it just makes sense to me. Hey, you have a question from Jason Oko in the chat that is interesting, Bethany.
While Bethany's looking at that, I do need to do a bit of housekeeping real quickly. There's an individual who joined, or multiple individuals who joined our meeting with a name that we can't identify, that is Anojan. We have asked that person to identify themselves through the chat function for the purposes of maintaining an attendance list. Please know that we are very excited to have anyone attend this meeting. However, we are also equally sensitive to the fact that we've been Zoom bombed. And so while we are excited to have people join, we need you to identify yourself. If you don't mind sending a message regarding who the Anojan person, the person who joined a little while ago is, we would really appreciate that. We don't, again, we're an open meeting, but because we have been Zoom bombed in the past as Maine EMS, and because that was very unfortunate, the nature of the things that were done to us, we are very insistent that folks make sure they identify themselves. You don't have to necessarily change your change the name that you use, but we do ask that you chat back to us and get back to us regarding who you are. And Chris had reached out to everyone to try to figure that out earlier. So please do that. We might have to move you to the waiting room if you can't identify yourself just now. So please send Chris or myself a message or the whole group a message to identify who you are. That would be helpful. Sorry, Bethany.
Jason mentioned that he's inspected services that do have unit dose packaging. This is something that I thought was not possible. I could re-look into that. I know it will be an extra burden on the dispensing pharmacies to package nitro individually. So I guess services would have to work that out with their dispensing pharmacies. But if that's an option, then I don't see a problem with that.
Bethany?
It still doesn't address the spray for multiple patients though.
They can just put the spray in the unit dose things. You just shake it out into their mouth, underneath their tongue. That's how that works. Question. Is it possible, and I imagine Joint Commission will probably have a stroke, is it possible for there to be a exchange? Like say EMS has a vial, they've broken it to give XYZ patient one dose. Is it possible for them to exchange with the nurse, like the nurse pull out a vial from y'all's dispensing system and they exchange with the EMS? That way EMS now has a new vial and the nurse can continue to use that vial with the patient?
I don't think that would fly. Like you said, Joint Commission might have a stroke, although they don't inspect emergency departments as closely as I personally wish they would. I think that the exchange process that they would use for any other medication would apply here. I'm just not sure about the continuing to use the product that they had taken from the ambulance, because you can't guarantee storage and whether it was tampered with. And I don't know many nurses who would be super excited about using something in that kind of way, but I could explore it.
Bethany, I also was looking at those last two sentences, and I think that we may need to soften the language there a little bit. I might recommend that if we wanted to leave something there about not leaving this medication with a patient, that would be fine in my mind. But I will say that Sam and I have been having a long-standing discussion dating back to the pre-pandemic era about the value of EMS providers leaving naloxone with patients who refuse transport, for instance. And we are actively working on that with a couple different folks, with some legislative language that we're proposing. So that is that idea of this being within the scope of practice is actually a changing dynamic. And so to come out with such a widespread comment, especially as we're attempting to reevaluate that concept, might be deleterious to our future messaging. Would you be okay with that kind of change?
Yeah, absolutely. I hadn't even thought of it until I had received it in an email that they suggested that they had been leaving medication with the patient. So I was taking the opportunity. So
Yeah.
Yeah, so we are, so that bill will likely come from the governor's office as part of their, a larger opioid related bill. But it will change pharmacy regulations to allow EMS clinicians specifically to leave to dispense naloxone in particular. And so it will give EMS just that one medication that they will be able to dispense. And so I certainly do agree with you that I think there needs to be some language around it, because I don't want people to think that, you know, we can just start handing things out. I know people aren't doing that, but, you know, I don't want to give this wrong impression.
yeah, I think making it more specific to nitro would be totally appropriate.
With the amendment of that language to be a little softer and reference not leaving this medication with the patient, is there anyone who feels strongly about making a motion regarding this?
I motion we accept as edited.
Do we have a second?
I will second it.
Is there any other discussion?
Jason has put me in touch with the pharmacy that dispenses the unit dose packaging. So I'll get back to you guys if your services are asking about it later.
All right, so the motion is to accept this position paper, which essentially recommends that nitro in whatever form be used as on single patients. So not to use the same vial or spray on multiple patients, acknowledging that there is a cost associated with this, but also acknowledging that this puts us more clearly in the regulated practice across most of other healthcare. Thank you to Tim and Kate. Hearing no other discussion, why don't we do a roll call vote?
Matt?
I'm sorry?
Sorry, this is Sam. One question. Should we put some kind of caveat at the end of this to say we understand that agencies may have used this practice, and we ask that they make the switch as quickly as possible, but no later than, you know, February or March? I just don't want people today to feel like they have to upend the entire system today because you released this today. You know what I mean?
There will definitely be logistics with the pharmacies as well. So that may be a good idea.
And Joanne or others on the call may have some recommendations as far as a timeline that it could be executed. I think it should be done as quickly as possible, but I also know that there are logistical concerns around that. And I don't want people to feel as though they're going to be hauled in front of the investigations committee if they do it today.
I'm going to speak for Joanne, but I think most of our hospitals are 340B, so this won't really affect my region too much.
I would, since Chip Getchell from Delta expressed a concern, you know, I wonder if this is no later than a July 1, you know, because it may affect people's budgets. But I certainly hope we may be able to find some suppliers that are less and help these agencies out.
I have a hard time with that one in particular. I totally agree that the financial burden of this sucks, But if we're writing this because of the pandemic, I think putting a deadline of it of 7 months from now is probably not helpful. I think just the as soon as possible language is probably the best we can do.
Also, Matt, nitroglycerin does not have an E on the end, but thank you.
Well, Microsoft Word thinks so. So Chip is saying as soon as practicable.
Many people might not see this as a practical change, so possible might be the better word.
How's that? Seth is saying about the next time you replace this medication.
Coming from a pharmacy standpoint, I would come after you for that one.
What if we were to use Mike's language with a bumper and say the MDPB requests that logistical changes to amend this practice occur as soon as possible and definitely by March 1, 2021. That gets people through the holidays and gives 2 months to address this. Does that sound reasonable? And Chip, I'm curious what your thoughts are about that.
Hey, Matt, can you hear me?
Yeah, I got you. Yeah.
Hey, I will figure this new computer out at some point. No, March 1 is fine. I mean, we order a lot of product, every month. So we will look forward eagerly to information from Bethany if there's a single dose alternative, and we will get that as soon as we can possibly get it and swap over.
So we've made some amendments to the motion that Tim made and that Kate seconded. Are you okay with these changes, both of you? Tim, I see you nodding your head. Kate, I hear you saying affirmation. Yep. Any other discussion as a group? All right, hearing none then. First, Bethany, thank you for guiding us through this. I really appreciate it. Let's take a roll call vote. I am in agreement with the motion. I am a yes. Kate?
Yes.
Mike?
Yes.
Seth?
Yes.
Tim, I know you made the motion, but we need your affirmation.
Yes.
Thank you. Dave?
Yes.
Beth?
Yes.
Benji?
Yes.
Thank you. Kelly?
Yes.
Bethany?
Yes, as long as you can add leaving this medication with the patient.
Done.
Thank
Pete?
you.
Yep, bet.
Claire?
Yes.
Adam is not here. Ray?
Dang it. Yes.
We're still having some trouble. Sorry about that. Thank you for all of you for that. All right, so I will make sure to send this back to the group and include that what I was working on back to the group and include Sam and Chris on that, so that everyone has a copy of the final version of that so far. Okay, thank you for that. Any other questions or any other thoughts about medication shortages or any of the other any other medication or formulary issues folks want to bring up? Okay, hearing none, let's move on to our next item. So I want to give some background for any of our members who weren't able to make our Monday meetings the last two times. The next item I wanted to talk about was our COVID related discussion, specifically around vaccination. So as many folks know, vaccines have entered the state as of Monday. I know some of you have been vaccinated already. In fact, I think a number of our MDPB members have already been vaccinated because of their status as practicing emergency physicians who are seeing patients and patients with COVID and PUIs. Many of you also know that we have been working in an attempt to try to support any discussions that you're having throughout the state with your EMS colleagues. We've been hoping to support that by creating a talking points general reference paper. I sent you all a draft version of that a few nights ago just to get an idea of what we're working on. That was specific to, or that was contemporaneous as of the 14th, I believe, where at that point we had only received the big information from Pfizer. All the information referencing Moderna were from their press releases regarding their interim data analysis and their phase 1 information. As of yesterday, Moderna has released their EUA application. Their EUA hearing with the FDA's Vaccine and Related Biologic Agents Advisory Committee is tomorrow, the 17th. And so we should know very, very quickly from the FDA and the VRBRAC what the recommendation is with Moderna. The ACIP has offered to meet immediately thereafter and give further recommendations on their thoughts of regarding the vaccine. So it is feasible that Moderna's product, if all goes well through the FDA and the ACIP, will be in the state sometime early next week. That's an important milestone for us as a state because it's the Moderna vaccine, which requires regular freezing temperatures and has therefore been adjudicated as the most appropriate logistically for our EMS agencies to be offered. So as Sam mentioned, we have a number of EMS agencies that have been applying through the state and federal systems to become vaccine recipients and vaccine distributors. And so starting yesterday, after that information came out, we scurried to update the general reference and talking points paper. I'm just waiting for a few other eyes on it to make sure that that it looks good, and I'll send it out to everyone. In this form, we are hoping to make widely available to anyone who's interested from public safety, since our first tasks will be to vaccinate EMS clinicians, followed by all public safety. So this is intended to be a reference for anyone. So that's the first thing. I'll work to get that to you guys today. The other piece of information we've been talking about for folks who haven't been able to attend those meetings is that we want to create forums to allow EMS clinicians to discuss vaccination with us. Kate and Mike and I had a very informative conversation with some of our colleagues in EMS yesterday. And I think it's really important to recognize that everyone is going to need to go through their own process to feel comfortable with vaccination. And there are circumstances related to this vaccine in this pandemic and just the overwhelming stress that folks are feeling around this pandemic, which have the potential to collude against us. I think we also have to recognize that it is ultimately an individual's decision whether they do or don't get vaccinated. And what we can do, the best we can espouse to do, is to present in as transparent and unbiased a way all the information that we have, and then demonstrate our faith in the vaccine, both actively and through our own interactions with folks. But ultimately, the decision to become vaccinated is theirs. What we're recognizing is that there are people who are early adopters and people who say, I want this, I want it now, I want to get this done. There are also folks on the other spectrum who are not inclined to get this vaccine, but also not inclined to get any vaccine. And then there are more people, the vast majority of folks are in the middle, and they are really interested in this vaccine, but they also feel like they need more information to become comfortable with receiving the vaccine. And I envision our job as being part of the process to give more information to folks. And so to all of you who scrambled after our Monday meeting to set up times to have those discussions, have those forums, I can't thank you enough. I'm going to be working off my memory here, so please forgive me and correct me if I get it wrong, but I want to just publicly announce the timing of those meetings. So Beth Collmore offered to help host one of those on this Friday, which I believe is the 18th at 3 p.m. Tim Pay offered to host one of those the following Saturday, the 19th at 10 a.m. Monday, we have 3 of these scheduled. We have one scheduled with, I think Seth is the 10 a.m. Yeah, thank you. 10 a.m. Seth is going to co-host one of those. At 3 p.m. Mike Bohansky's offered to co-host one of those. And many thanks to Dave Sakay, who offered to host an evening forum in an effort to capture anyone who may not have been able to attend a weekend or any of the day or afternoon forums. And then we wrap up on Tuesday at 1 p.m. I think, Benji, is that correct? Yeah, 1 p.m. with Benji hosting one of those. We kind of took a little bit of an approach similar to the way that we've rolled out protocols, but acknowledge that these are not physical meetings. They're going to all be Zoom-based meetings. So while each of the regional medical directors' office offered to co-host these, and we want to try our best to get their trusted voices out in their local communities. Please know that just because Benji is co-hosting one of these, that folks from any of the other regions can still come. And we wanted to make sure that there were ample opportunities that extended over weekdays, weekends, days, afternoons, and evenings, so that we could cast as wide a net as possible. Many thanks to Sam and Mark for behind the scenes logistics regarding this. And for anyone who's interested, Mark just put in the chat function a web link that can direct folks to not only the times of the meeting, but the Zoom information. Please know that we are using a different Zoom room than the one that we commonly use for most of our MDPB activities. We're doing that deliberately for 2 purposes. Number one, this Zoom room only affords us the opportunity to have up to 100 people in it. And in the possibility that we get more than 100 people showing up, we wanted to have capacity. The other thing that the other Zoom room allows us to do is record, possibly live stream, but also make available at a distant time the conversation that we're having, so that anyone who can't make any of these meetings still has the opportunity to hear your voice regarding the vaccine. As far as agendas for this, the reality is that I do believe there is going to be importance in having some structure to the conversation. And many thanks to Mike Bohansky. He and I have been talking about putting together some slides that we could all use to try to offer structure and offer some commonality. Those slides will be supportive of the general references and talking points paper, which I'll send you later as soon as I get some comments back from some folks. But the biggest piece of the puzzle here, I think, is the opportunity to have an open dialogue with folks and to allow folks, allow us to meet people where they are, and allow us to walk through their concerns and to attempt to demonstrate the science to them that we have available. We live in an interesting time for this. There's lots of information bombarding folks. Some of it is legitimate, some of it is not. And admittedly, all of the safety efficacy data that we all yearn for has just hit the mainstream right now. And so I think our goal is to scurry as much as possible to review, consider, and then reflect that to folks who haven't had the opportunity to do so. One ask of everyone here, and this is an ask for everyone on this Zoom line, if you don't mind sharing throughout your contact lists, please share wide and far the information that Mark just put into the chat function. We really want to try as much as possible to make this inclusive. We want to get as many people in attendance as possible. I recognize that there will definitely be other conversations that happen after that, and that is awesome. But we want to highlight your trusted voice and your presence to folks as much as possible as the MDPB. And I want this to be the first of lots of conversations regarding vaccination. One final logistical piece before I open it up. I want to be sensitive to everyone's level of comfort. And so before each of these I mentioned, I will reach out to you actively to kind of talk, fine tune the way that we present this information. We'll have those conversations before the meetings on the days described, both Friday, Saturday, Monday, and Tuesday. Any thoughts, any comments, any ideas folks have regarding this?
As I'm building these slides, guys, some of the stuff that I'm trying to build in, it's a lot of the talking points pieces that are in that document. But the other piece I've tried to put in here are some of the like frequently asked questions things. So if you have come across or have been hearing a lot of the same question over and over again, shoot that to me, email, text message, chat function, whatever. Because we want to, while the town hall, people feeding us questions and us answering them is going to be kind of the main focus of this. Those frequently asked ones we'll just throw up there and answer immediately just to kind of get it started. So please don't hesitate to send me some of those things.
And Mike, do you want to just update folks on the timeline for the slides real quickly?
Yeah, with any luck. So we are, Matt and I are meeting this afternoon. I know that we're running up on a real timeline here with the first session being Friday. Our goal is to get these slides out tomorrow. That means that Matt and I have reviewed or are actively reviewing all the Moderna EUA stuff so that we can try and get as accurate of information in here as we possibly can, since that is the vaccine that will be allocated to our providers. And we'll do the best we can. It's obviously it's a short time crunch here and a lot of information to try and digest and get in here, but we'll do this in a way that has references, has links available, and has quotes from the primary literature, so that you've got stuff to back up any statements that are made on the slides.
Yeah, and just for everyone's information, what we will do is we'll take basically those slides and condense them into the online education. So not only will you be able to get it here, but some of it will be condensed and put onto the online education that Maine EMS is building out. And so one question I know I sent this to you, Matt. We need to provide some guidance as far as those individual clinicians who may be pregnant or who are pregnant or may be pregnant. Just guidance of you should speak to your OBGYN before you come to this conversation. So that way you're not having to make that decision, or because I want them to know that they need to think about these things before they are sitting in the chair to get a vaccine, because I don't want that to be the time that it's kind of discussed. So I would love that, we kind of mention that, is that, hey, if you are pregnant or maybe pregnant, these are things you need to consider. There isn't a lot of data out there. We think it's important for us to be transparent, but I would really love for them to kind of be thinking through that before they get to that chair to get the vaccine.
Yeah, thank you.
Yeah, so I think, so Jason and I had a conversation by phone yesterday, and Sam and I and Kate were emailing back and forth. There are, and for anyone who's been vaccinated, that there are forms you fill out regarding whether or not you're feeling well that day, if you've been experiencing fevers, if you've had any adverse reactions to any vaccine, if you have any known allergies to the components of this vaccine, if you've had a reaction to this vaccine, et cetera, et cetera. And we will need to script out similar questions for EMS agencies who are vaccinating folks. And I believe that the way that Sam presented this is going to be important. I don't know if we are going to be able to build comfort amongst our workforce in having a high-level discussion with folks about the pros and cons of vaccination during pregnancy. But I think what we can do is to highlight and be transparent about the uncertainties in pregnancy, and allow an individual who might be pregnant or who is pregnant the opportunity to just have a brief timeout and say, listen, we don't know everything. There are major bodies that are recommending vaccination. And for those of you who haven't seen it, ACOG, or the American College of OB/GYN, have recommended that pregnant women not be excluded from this, but they've also commented on the importance and value of conversations regarding this. And so I don't know if we are the right body to be having those conversations, but I do believe we should reflect with anyone who could be pregnant the importance of those conversations should they choose. There might be folks who say, nope, I'm moving forward, I've looked into this and I feel okay. But there may also be folks who say, oh, that's a good point. I want to have that conversation first. And I think we just need to build in that possibility for anyone who's presenting to one of our colleague EMS clinicians who's providing vaccination. Tim, your face looks like you're feeling consternation about that.
No, I'm just actively reading it. The ACOG statement, that's all.
Okay.
And I am very appreciative of their input.
Yeah, it's wonderful that they have worked so hard and done they've been diligent in interpreting the limited but available data on outcomes. Moderna's information is fascinating. There are few women who didn't know they were pregnant initially, but who became or found out they were pregnant throughout the trial. All of the pregnancies in the vaccine group are presently progressing as expected with no identifiable complications right now. But again, we've had 8 to 12 weeks of experience with very limited cases. And so we need to be realistic and transparent that we don't know everything just yet. And that's the importance of these conversations with a individual's obstetrician. Any other final thoughts or any other thoughts about the vaccine, our messaging as a group? Anyone else have anything else they'd like to add?
There was a pediatrician being interviewed on our local NPR station yesterday talking about the vaccine conversations they have routinely with patients and families, and describing her approach as brutal transparency. So that is what we are going for with this slide deck, is all the information we have provided as cleanly and basically as we can.
Well, again, I can't thank enough all of you for everything you've done here. I really respect your investment in this and your commitment to messaging and really helping our colleagues in EMS make these decisions. And these are, for some people, these are very, very hard decisions that they're wrestling with. And we may not even know the circumstances that make these difficult decisions for everyone. So your willingness to be open, your willingness to meet folks where they're at, your willingness to converse with them about their fears and do your best to assist them as they think about these things is, I can't tell you how much I respect that and thank you for that. And I'm really excited to start these conversations up. I really hope they're helpful to folks. Let's keep in touch about that and make sure that we're meeting our goals as we move forward, and go from there. I will say, just as an aside, I was looking at our numbers again today, and for those of you who haven't seen yet, we hit the first day in which we've had more than 500 reported cases of COVID-19 in the state of Maine. It's only been a few weeks since we hit the 300 mark, and then since then we've had a number of days where we've been over 400. We are in the throes of this right now. And while there is no way we're going to change our current protective posture and that vaccines will not change the PPE we wear today, it is really heartening to have this opportunity and to take our first offensive stance against this vaccine. We are in the throes of this right now, though. And as this progresses, the value and importance of the potential for vaccination will become increasingly highlighted. And so again, your efforts around this are awesome so far. And I can't tell you how much I thank you and respect you for taking this further. So any final things around COVID or vaccination?
My plan here, sorry, one last little piece here is just for this education is going to be on vaccine science and the decision to get vaccinated, not the logistics. So we're not going to get into in this where the vaccine is going, how it's getting administered, who's first, any of that kind of stuff. So we're going to leave that up to the Maine EMS published plans and the services that are doing that. But this is just going to be the trying to answer the questions for providers so they can answer for themselves about whether they're going to take the vaccine.
Once again, thanks, Mike, for helping out with that. Okay, let's move on. So our next item on the agenda is our protocol work. We passed another important milestone last month in that we got through the red section. Thanks to Mike and Seth for that. We are now on to the gold section. Many thanks to Dave and Seth for working on that for us and for putting together information for us to consider today. Real quickly, before we get there, I just want to share again with everyone where we're at. So I'm pulling up right now our timeline. So if you look here on the screen, this time last year, Kate and I were looking at this and we were hoping that we would be well into the greens or beginning the green section this month, and that we would continue that next month. We'll have to see how today goes. We were hoping to be done with the gold section by this time when we were originally planning. Thanks to everyone for getting back to Kate's Survey Monkey about the possibility of another meeting time. I was going to ask her before she walked away to help remind us when that was. Here she is.
April 23rd.
April 23rd. No, I think, is April 23rd the retreat or is that the meeting?
That's the retreat. I think the meeting's January 20.
Oh, just kidding. I meant the retreat. It's the 23rd.
Great.
January 22nd.
Yes, thank you very much.
Yeah.
So we'll have to see. We'll keep in touch in all of these meetings to see where we're at, but I anticipate that we will need that time. So thank you guys for all making that time available. You know, I think I've mentioned before that this has been one of the harder protocol processes to predict, just because there have been so many other obligations that have that we have had arise, and so many other things that have taken our attention. Not the least of which have been the response to the pandemic, which is essential. So I'm keeping a very open mind about this, but my fingers are crossed that we can make the originally delineated deliverables occur. So more to come there. I did want to mention that let me just pull up my notes here, that we did not have a protocol discussion forum this month, but we do have one scheduled for the 7th, January 7th at 2 p.m. So for anyone who can make it, it'd be great for you to attend, especially folks who are proximate to the conversations that we're having at that moment in time. So gold folks, green folks, et cetera, et cetera. So please, if you can make that time work, please consider doing so. We'd really love to have your voice at that. And again, that's January 7th at 2 p.m. Kate, any other kind of general protocol things that you can think of that I'm forgetting before we jump into the gold section?
My only ask is that when your section is done, if you can update your change document so that we can get those posted.
Great, thanks for that, Kate. Thanks for that reminder. All right, anything else folks want to mention?
Matt?
Yes, Sam.
Before we get off all of the COVID chat that we've had so far this morning, just letting people know that there likely will be updates to the playbook that will come out in the immediate future with guidance that we're receiving from CDC. So just people remain aware of those changes. We will put out notifications regarding that. So just make sure you're staying aware.
Thanks for that, Sam.
Hey, Sam, on those edits, does it make sense to put like the new information in red or some other way to notify so it's easy to see the edits as opposed to reread the whole thing?
We just so happen to have a change document page that is, I think it's the 3rd page of the document. It says change document, and it says exactly the page number and paragraph where the change was made.
Beautiful, thank you.
All right, thank you for that, Sam. Dave, what's the best way for us to proceed? Do you want me to put the slides on my screen and for everyone to follow along with that? What's best for you?
Is it, can I share the screen under this current thing? Because I had a couple of small changes, but I don't think I sent you the most updated version of the PowerPoint. I mean, would you like me to just send it along and you can do it, or?
I just made you the co-host, so you should be okay. If you don't mind though, putting them in the Dropbox when we're done so that everyone has the most up-to-date stuff, that would be great.
Of course. Let me get this shared. All right, you guys got that?
Yes.
All right, so there's not a lot here. Like I was talking to you about the other day, following Mike and Seth through this. I mean, they did all the heavy lifting last year. I've got a couple of small things that I wanted to add. The first one was actually brought up to me by a member of my region, one of the EMTs, who pointed out that there's no real, there's nothing in this protocol that lets EMTs consider a second dose of anaphylaxis, of epi and anaphylaxis. Don't know if we talked about this at a previous meeting or where we landed on it, but just wanted to bring this up to the group for discussion. If you'll notice in the basic EMT, there's a couple of different ways that they administer epi, right? Either if they're not trained in administering it through Ready, Check, Inject or an EpiPen program, then they end up administering the patient's own epi. So I can see where they wouldn't do it in that. But for the people who are trained, I'm wondering if there isn't a way that we could sort of put in either contacting medical control, calling the hospital, or putting the same IM epi dose with a call the hospital thing that we do for the paramedics. I don't know what the answer to that is. Just wanted to bring it up to the group.
I think that makes good sense, especially if you have a BLS transporting agency that doesn't have the privilege of a paramedic backup. I don't know why we would not allow a call to online medical control at a minimum to consider second dose. Good catch.
Love it. I can't take the credit. It was, let me pull up the email. It was Jack Indritz, one of my region providers. So I can't take any credit for that. A man can only see so far on the shoulders of giants, I guess. Still stands true. So I will, when I get access to Lucid Chart, I will put that in there if that's okay with the group. I'll put the same language that's in line 10. I could move 10 to 6. Does that sound reasonable? So that way that it's all happens at the EMT level, then the advanced EMT can continue on with that as with the paramedic. Does that sound reasonable? All right.
Yeah, so Dave, we've been, just because we're doing this all virtually, and it's for the purposes of transparency, we've been having motion seconds and roll calls. Do you mind if we do that here too?
Oh, no, of course. I'm under rested and under caffeinated. My apologies.
The only thing I think that's really important is that there's a small body of literature that we found when we were reviewing anaphylaxis through the Pegasus project. And there is a small body of literature that discusses a single dose of epi for mild symptoms that don't recur. Those might be folks that that don't require transport. We never built that into this protocol, as you can see, but I think we really should make sure that, well, I wonder if we need to make sure that, especially once you're giving a second dose of epi, that person really needs additional care at that point in time and must be transported. Again, it's not currently in our protocol, and maybe we don't need to address that, but it just struck me as we were talking there. I wonder if that might be something else to consider.
Hey Matt, I was actually, sorry, I was gonna say, I was wondering the same thing as I was looking a little closely at line 10, and I wonder if we can't clarify when or why to repeat the epinephrine, which is, I think, kind of what you were saying, is that it's not always indicated to repeat it. And I don't have the language for it, but I just think that perhaps some sort of guidance might be important.
Do you think that belongs more in education? Rather, a question for the group. That's just what the first thought. Just trying to keep things streamlined, but I think that's more of an education piece. Benji, that it could be addressed there, or do you still feel like it should?
I wonder, I always hesitate, and again, I'm the newest to all of this, so take what I say with a grain of salt, but I always wonder, that the education bit gets a bit buried, and that, if you're pulling this open because you're dealing with a sick patient, critically ill, that you have time to read all of it. And so I think having a little bit of some direction here, and then maybe some more in the education can be good. Maybe something like, if symptoms persist or if symptoms reoccur, repeat, and then maybe have something that directs down to education where you can kind of discuss what those symptoms might be or something like that.
Well, down in the pearls, there's the the criteria for the anaphylaxis. I guess I was laboring under the assumption that they would know that if those symptoms resolve, they wouldn't just administer a second dose routely. I haven't personally noticed a problem with any of that in my region. Have any of you guys had problems with people just kind of willy-nilly given a second dose? Because I think, I totally agree. I mean, you shouldn't just routinely redose everybody. And I feel like the people with the least amount of training are more prone to doing that. But I also look at it, if a person's symptomatic and the only person there is a basic EMT, the patient doesn't have a history of anaphylaxis, so it doesn't have any epinephrine on their own. I don't see much harm, but I mean, that's just me. I mean, maybe I'm not thinking through the whole thing, and I absolutely appreciate anybody's input. So,
well, Dave,
that's kind of where I was at with it. But
if we look at, if we were to review the literature, for instance, I actually have less concern about folks giving epi willy-nilly. I think the literature would suggest we don't use epinephrine either as emergency physicians, emergency nurses, or EMS clinicians. We don't reach to epinephrine soon enough. And so maybe highlighting that in here and what Benji was saying. And I like Benji's kind of idea of a, not necessarily fully educational, but also just saying something along the lines of for persistent symptoms or signs of anaphylaxis, and then leading into number 10 stuff there, repeat IM epi, et cetera, et cetera.
Do you think I should throw that? Would that be reasonable to put in the pearls?
I think your first idea of pulling number 10 up into make number 10 the new number 4 is reasonable.
And then for the educational part of we don't use it enough, to maybe throw that in the pearls, the first block of pearls, because there's a lot of pearls on this one. I mean, if you think that's, I mean, I'd be happy to put it there. Let me just put that on my to-do list for change documents.
I would completely agree with what Matt's saying. I think that, that was always sort of beat into me probably by Matt in residency, but that certainly we should talk about how it needs to be used with a low threshold. But I guess as I'm reading it now and thinking about more of that line 10 we're talking moving up, I think that by the syntax, if you read it, the instruction is repeat it every 5 to 10 minutes. Right now it doesn't say based on your judgment or if it persists. Right now, technically the direction is, do it like this and then repeat every 5 to 10 minutes. And so I think we do need to put some sort of something in there to say if symptoms persist or
You're right, for persistent, severe, or worsening symptoms. Because you don't want them to give it for just a rash, right? You want them to give it for persistently severe or worsening symptoms of anaphylaxis.
So
I'll put that in there.
Persistent, severe, or worsening signs or symptoms of anaphylaxis.
Right.
Which are all, if you look at the pearl on, it's page 59, gold 3, it says, the pearls for allergy anaphylaxis, it says is highly likely when any one of the following 3 criteria are fulfilled, and it has these, these 3 little blocks. So I think that pretty much addresses that. I love the adding though, if persistent, severe, or worsening symptoms is in there, because as Benji pointed out, the syntax is like, it says just give it. So I totally see that, and I hadn't noticed that before. Or I'd probably seen it, but had not appreciated it, as we would say in the business.
All right. Does anyone feel strong enough about this to make a motion?
I'll make that motion to
I'll second.
accept the changes.
Oh, come on. Just wait till we get all back in person here. It's going to be ruthless.
This is going to be this is going to be a big motion, man. I'll be impressed.
So Benji, are you okay? Just because I'm taking notes for us so that when we have to get into Lucid chart, does the following for concrete language around the emotion resonate with you? So we're going to change the language number 10 to say for persistent, severe, or worsening signs or symptoms of anaphylaxis, repeat IM epi, and then every 5 to 15 minutes, call for paramedic and notify online medical control of incoming critical patient. Moving number 10 to number 4. Is that the motion? Does that capture everything?
I would say I would make the motion as stated. Yes. Thank you.
All right. And Kelly, you're okay with that clarification of the motion?
I'm okay with that.
Great. Any discussion amongst the group?
Then we also had the, do we need to motion for the add if persistent, severe, or worsening symptoms, and then add the educational piece about not using enough epi in general, or would those be separate things? Can we lump them all together?
So I think we've got the for persistent, severe, or worsening signs or symptoms in the motion. The added piece about just including a pearl to or at least clarifying the definition, Dave, and referencing utilizing epinephrine in those circumstances, and just acknowledging that we don't use epi soon enough or frequently enough in all of emergency medicine. Is that what you're referencing?
Yeah,
Okay.
that'll be like a
Benji-
one-liner under the first pearl there.
Yeah, Benji and Kelly, are you guys okay as the motion and the second to include a pearl like that?
Sounds good.
I would love to, yeah, hear that pearl fleshed out. Not right now what I'm saying, how we end up doing it, but yeah, I agree, it's very important.
Why don't we do this? We'll work on the pearl offline. I can help you with that, Dave. And we'll bring that back to the group for final consideration.
Sure.
So the motion will be that we will add a pearl to be considered later on. All right. Any other discussion? All right, hearing none. Ray, you want to start us off? Are you in favor of this?
Yes.
Great. Great to have your voice back, by the way. Claire, are you okay with this?
Yes, I am.
Thank you, Claire. Pete?
Sorry, I couldn't find the unmute. Yes.
Thanks. Bethany?
Absolutely.
Thank you. Kel?
Yes.
Benji?
Yes.
Beth?
Yes.
Dave, are you cool with this?
Of course.
Tim?
Yes, please.
Seth?
Yes.
Thank you, Seth. Mike?
Yes.
Kate?
Yes.
And I am a yes. Thank you all for that. Thanks, Dave.
Thank you. All right, and then next on to seizures. So if you look in the seizure section, let me grab the actual protocol book. There we go. So under, if you look under the seizure section, so for section 2, it says for people who are visibly pregnant or less than 2 weeks postpartum who are having a seizure, presumably, it says give mag sulfate 4 grams IVIO or 4 grams in each butt cheek. And then contact MedCon for the following options. So it seems to me that it says 14 do this, and then 15, it almost seems like it's as necessary. So I would propose to add a hospital sign after this one, because if you're given a mag sulfate for an eclamptic seizure in the field, I feel this is the kind of thing that I don't want to just go through the standard radio notification process and potentially get overlooked and say, is this, you know, can you put this patient in hall C and we'll get to him when we can? Like, this is the one that I want to know about, like, as they're rolling through the door, because these are complicated. That's just a thought. It doesn't really represent a huge change to the protocol, but I don't know how many of you thought about that. I just don't want that one to be overlooked, you know?
I would completely agree. I think these are ones I 100% would like a heads up for.
So one of the discussions that we recently had with some providers was just in general to give a heads up for any repeat dose. And I think this is exactly what you're getting at, but also to make a note about, you know, either preparing medications or being ready to administer at 5 minutes. I don't know if that goes hand in hand here, but really just emphasizing exactly what you're saying is that we need to make sure that we are administering anti-epileptics early in the field, repeat doses early, and giving a heads up to our department so we know they're coming in. We can prepare, you know, whether that's our Keppra or a phenytoin drip. And then just as along the same lines of making some changes here, that's number 14 into 15, but we actually jumped from 9 to 14. So if we can renumber those at the same time.
Hey, there you go. I didn't even notice that. So yeah, I think let me see. In the next one, I have a little bit more about status in that one. This one in my head was anyways specifically about the eclamptic ones, because I don't know, like if you're given mag, I'm starting to worry. You know what I mean? I think these people are sickety sick, of course. So that, and there'll be more about that in the next slide. So thank you for bringing that one up. Let me put this in the change document for. So you guys okay with adding the hospital icon?
Yeah, let's focus on that one right now. We can get into the next piece with your next slide. Does that sound cool, Dave?
Yeah, of course.
I think it's very reasonable to have a hospital sign next to number 14. I agree with the folks who've spoken up. Those are potentially very complex patients, and having notification of an incoming pregnant seizure, a eclamptic patient is tremendously helpful. So I'll make that motion that we place an H next to 14.
I'll second.
Thank you, Bethany. Any further discussion about that? All right, why don't we do a roll call vote then? I am in favor of that. Kate?
Yes.
Mike?
Yes.
Seth?
Yes.
Tim?
Yes.
Dave?
Yes.
Beth?
Yes.
Benji?
Yes.
Kelly?
Yes.
Bethany?
Yes.
Pete?
Yes, thank you.
Claire?
Yes.
And Ray?
Yes.
Awesome.
All right, so then the next one, so this is this continues down the status epilepticus non-preeclamptic patient, or non-eclamptic patient. So when you're following this down the pathway, first off, the Pearl, the highlighted section here, I'm sorry, I used an image capture thing on the Mac, and I don't know if you guys can read that all very well. But basically taking that highlighted section out, it says contact online medical control for a patient requiring 3 or more doses of midazolam, independent of the route provided, and just putting in a hospital icon that says, in the protocol that says contact medical control if a 3rd dose is given. Just again, to let us know about these patients, because if you're rounding the corner for 3 doses, and the only way in an adult, the way I read this, that you're going to get to dose number 3 anyway, is if you happen to have an IV in place and you do the IV dosing of Versed, because if you do the IM dosing, you're going to give 10 times 2 for a max of 20. And then if you do the IV dosing, you're going to do 5 milligrams IV, 15 milligrams IV. So if you're doing the IM dosing, you're only going to do 2 doses. So you'll never notify MedCon. I don't know if this is something that we wanted to address. This is basically just sort of like a housekeeping thing. This isn't like anything substantive changing to the protocol, you know?
So Dave, your thoughts are to take this piece out of the Pearl and put it into the protocol. Is that correct?
Yeah, so the Pearl part that says contact OLMSC for any patient requiring 3 or more doses of midazolam independent of the route provided. I think that if you look under the paramedic part of 9C, where it says if seizures continue, repeat midazolam at above doses, IV, IO, IM, Q5 minutes until resolution of seizures. And then it says for a total of adult 20 milligrams IM or 15 milligrams IV. So if you look at that, if you do 20 milligrams IM, you're only going to do 2 doses. Does that make sense?
Yeah, no.
So under this one, so under the Pearl, you're not going to really call MedCon if you're using IM ever, unless, you know what I mean? Does that make sense? And these are the patients that, again, that I would like to know about rolling in the door. Like, I don't want to find out about this when I pick them up after they've been here for 90 minutes after they've had a few standing orders put in, you know?
So I think a couple of things strike me as I look at the protocol myself. We authorized the repeated midazolam in 9C, but then in 9C1, immediately under that, we asked for online medical control. And so it kind of seems like not necessarily clear if we want online medical control for those repeated doses of benzodiazepines or not. I would offer that I don't know that we gain much juice from the squeeze of asking a physician if we can give more benzos when someone's actively seizing after their first dose. And this might more appropriately be a notification, because the reality is if you're still seizing by the time we get there, you are by definition in status epilepticus at that point in time. And if you are still seizing after your first dose of benzodiazepines, you are only more in status epilepticus. And just like the conversation regarding eclampsia and MAG in a pregnant woman, I think, like Kelly mentioned, having a lot of heads up about this incoming patient could be beneficial to the hospital. Not necessarily should I give more benzos, because should I give more benzos in this situation should be uniformly yes. But I've given more benzos and they're still seizing, and we're coming to you, I think is the right step in my mind there. So I would propose that we do what you're talking about, but I might even propose that we're a little bit more, that we take away online medical control there, but we leave an H if the second dose of benzos are given, because the reality is at that point, the patient is in crisis from their seizure, and knowing that they're incoming could be very, very beneficial. Does that resonate with anyone else, or does that sound reasonable?
Yeah, absolutely.
Yeah, I agree. I don't know that we need to be a rate limiting step here, but early notification makes a lot of sense.
Can we write it similar to the way that you're just saying, Mike, and just say early notification to the
I
hospital?
would propose yes. Let's move forward with that.
Sorry, just to say it, just like you're saying, Mike, early notification to the hospital if administering a second dose of benzodiazepine or a second dose of anti-epileptics.
You can see Matt furiously typing. I assume he's drafting that exact statement.
Yeah, I'm saying that what I'm basically saying is that we replace 9C1, which currently reads contact online medical control of additional midazolam as necessary. And I would offer that we take away the online medical control piece of that, and we say something to the effect of notify the hospital as soon as possible if any repeated doses of midazolam are necessary. And if we want to clarify why that's important in here, we could add in a little bit that says this allows the emergency department to prepare additional medications beyond benzodiazepines to deal with a very sick patient who's in status epilepticus.
Do you want to reinforce the giving heads up to the hospital and putting that second statement that you just mentioned in the Pearl?
That's a good idea, Cal. Yeah, I like that. What do others think about that?
You're saying to put the so like we said, change the online medical control, which I agree. Like I don't like the mother may I thing. Make all LMC a hospital notification ASAP, and then reinforce that in a Pearl is what you're suggesting. It's very reasonable.
Yeah, I like that, because we're not deleting a statement to call. We're actually reinforcing, right? So smart move.
All right, who wants to make a motion?
I'll motion.
I'll second.
And you guys are saying that the motion would be to, let's see. So add hospital icon for repeated doses of midazolam for notification, change MedCon to hospital notification for second doses of benzodiazepines, and reinforce these two concepts in the pearls below. Did that sum it up?
Yeah, Dave, I'm taking notes for us. If I might, what I was writing down, if this sounds okay to you guys, is that to replace 9C1 to read, please notify the hospital of any additional doses of benzodiazepine are required, to remove online medical control and add an H, and then add a pearl that says patients requiring more than one dose of midazolam for seizures are potentially very ill. Early hospital notification allows the hospital to prepare for the patient and to prepare additional medications to stop the seizure or something like that. Whoop. Does that sound reasonable?
Sounds good to me.
Oh, goodness. And Kelly, I think you made that motion. Is that okay with you?
Sounds great.
All right. So Kelly, you made the motion and Tim seconded it. Is that right? Yeah. Okay. Any other discussion, any other thoughts about how to better word that?
You want me to just draft up a blurb after the meeting and send it out to the group?
I'm taking notes, Dave, and so I'm trying to capture as much of the language as we can now, so we reduce as much as possible so that we can just move as quickly as possible the protocols. If that's okay with you, I'll keep doing that. But like I said, it reads, what I wrote down is it reads to replace 9C1 with, please notify the hospital of any additional doses of benzodiazepines are required, removing the online medical control from that, but adding an H and then adding a pearl that reads something to the effect of patients requiring more than one dose of midazolam for seizures are very ill. Early hospital notification allows the hospital to prepare additional medications to care for the patient. Does that sound okay to you, Dave?
Love it.
Any other discussion? Hearing none, I'll do a roll call vote. I'm a yes for that. Kate?
Yes.
Mike?
Yes.
Seth?
Yes.
Tim?
Yes.
Dave?
Yes.
Beth?
Yes.
Benji?
Yes.
Thank you. Kelly?
Yes.
Bethany?
Yes.
Pete?
Yes.
Claire?
Yes.
And Ray?
Yes.
Awesome. Thank you, guys.
All right, so the next one I got is a change to medical shock. So the problem that I see when I'm working every day is for services with people who are dealing with septic shock specifically, getting medical control on the line. In my opinion, the ones that are most affected are the services that are somewhat close, working PB, and who don't have a pile of extra hands on scene. So this is a lot of our services. This is sort of a blurb from, the surviving sepsis guidelines, as we all know, early aggressive treatment, fluids, pressors, resuscitation, and then obviously source control, right? So what we found, I looked at this with some of my capital QA team. So 44 states in general have statewide protocols. 15 of those have standing orders for leave-of-fed and medical shock, one of which is New Hampshire. I think Vermont might as well, I forget. It was a while since I've read this. This is just a blurb out of the New Hampshire protocol. So if you look at this, it's sort of standing orders. Basically, it says if there's no adequate hemodynamic response after 2 liters of fluid, consider starting norepi. And it just basically says 1 to 30 micrograms per minute via pump, or start an epi infusion. This is for the adults. Pediatric, obviously, if you're starting pressors on a kid, I want to know about it. That's definitely a MedCon thing. So this would only be for adults, in my opinion. And sort of going through this, so if we follow the letter of the protocol and do med math, everybody's favorite topic. So if you start the Levofed as at our protocol specified rate of 0.03 mics per kg per minute, this is after you've identified a patient that's failing fluids, after you've got on the horn called MedCon, after you've gotten authorization to do it, and then after you've pulled it out of your bag, and then mixed it up and turned on the pump and stuck the thing on, then you start titrating it, 0.3 mics per kg per minute. What we specify is that the usual dose is 0.25 mics per kg per minute. Our maximum dose is 0.6. We titrate up 0.3 mics per kg per minute every 3 to 5 minutes. So if you do this as fast as you possibly can, it's going to take you 27 minutes to reach 0.25 mics per kg per minute. If you want to max out, it's going to take you a full 60 minutes. If you do the slow track, which is every 5 minutes, so the fast track would be every 3 minutes if you're really aggressive, it's going to take you 45 minutes to get to 0.25 mics per kg per minute. And I guess my thought is that I would never practice this way in my hospital. So I would never sit there and say, yep, I've got a person who's failing fluids and needs pressors. I mean, I start off at 0.15 mics per kg per minute and then titrate down if I need to, I mean, I've never had a case where I've achieved hypertension in a patient like this. If I started a slightly above the specified dose, or I start at 25% up, and I feel like probably most of us practice emergency medicine that way. So what I would propose is sort of modifying that, standing orders for levo, bolus levels, hospital icon, of course, notification, and then for adults only. And this is just sort of to open up a discussion with the group about how we should sort of manage this by our pre-hospital, in our pre-hospital situations, because basically I think a lot of people are showing up without pressors who would need them. And then when they show up, they get registered, they get thrown on the board, and it just seems to delay the care that we know they need a little bit more by making them have to go through the hospital registration process in order to even start the ball rolling. That's just my personal observation. Just sort of wanted to open this up to the group for a discussion.
Any thoughts about that?
No, I think the way our current, I think we have a lot of barriers to starting pressors here. Some of them are operational and pump intimidation, and others are med control. And I think we've inadvertently put up enough barriers that it inhibits this getting given when it should be. So I'm a big fan of pulling back on anything we can. And I think this is a very reasonable first step, which is to allow for giving this to adults without a med control phone call. So, and I look forward to continuing this conversation on pressors, right? And thinking about it. So I think I'm a big fan of this first step.
I'll offer some historical perspective. This gets discussed not infrequently. One of the conversations that comes to mind is when we actually made the transition from dopamine to norepinephrine. I can only imagine Bethany's pharmacy brain is going a little bit crazy using the trade name versus the generic name. So I'll use the generic
and
name.
the lack of leading zeros in Dave's slides, but we'll leave that alone.
I am but one man.
Part of the quandary we found ourselves in is that we did this very, very infrequently. We used pressors over the course of a 6-month period, less than a couple dozen times in the 911 phase of care. Like there are definitely more use in interfacility transports, for instance, but one of the thoughts at that point in time was that this is a rare occurrence, number one. Number two, there has been historically some just discussion about ensuring that we've maximized preload with adequate volume prior to initiation of pressors. And there had been at one point in time concerns in the opposite, that we weren't maximizing volume in certain cases. And there had been discussions with online medical control before the first liter had been completed. So I offer those just as some historic pieces of information to perhaps help you with some of the discussion.
I agree with, with that. I think one of the things that we would do is, I mean, we could just, my thought would be to protocolize and pick a dose of fluids that we found appropriate to, after which to initiate pressors, right? So, I mean, most of us standardly, I believe, would use 30 cc's per kilo for a medical shock patient. I mean, I find myself in my personal practice getting handed patients who are just ready for pressors by EMS. Like, they show up, they identify medical shock, they initiate the appropriate fluid resuscitation and fail appropriately. And by the time they fail, they're 5 minutes out. So then when the conversation that I hear from a lot of my folks is that they say, well, we're 4 or 5 minutes out. By the time I get a doc on the phone, get them to approve it, pull it out of the drug bag, mix it, and set up the pump, I'm already at the hospital, so why would I bother? And I feel like you were saying, a lot of the inadvertent barriers, Tim, that we throw up. I think that a lot of the reason that we don't see it used more is because of stuff like that.
Well,
so usually what happens is they get to the ER and I'm throwing them on. I'm getting the nurse to grab the pressors out of the Pyxes.
I just want to put in the idea for us something that strikes me, and this is a separate issue. We need to deal with this issue, but you're also bringing up the fact that our online medical control process is vulnerable. And if our online medical control colleagues can't rally around these patients, and if our system is so cumbersome that we can't find time to talk about the sickest patient that's coming to the hospital and perhaps the sickest patient that physician is going to see, that in and of itself, it needs to be addressed as well. And we need to deal with this now, but I don't want to, if the core issue here is just that our online medical control system is not good, we got to deal with that too, though, because I don't want to solve this problem for medical shock, but then have issues arise around STEMIs, strokes, traumas, or any other time critical illness, or any other cause of shock, cardiac arrest, etc. If we're acknowledging that the purpose of making this change is that our online medical control system is not good, we should also make sure we fix our online medical control system, because that is a cornerstone to our response, and that is paramount to the care of our patients.
Matt,
Matt, I think,
really
by way.
Seth, I think.
1, 2, 3.
All right, I'll go first, and then I'll let you jump in, Seth, right after me. I would be really interested in assessing the quality of our online medical control. Like, how do we know? And doing that statewide, that would be a really interesting thought project, and then something to carry through, and to spend some time outlining that, like what is a quality online medical control? Because with the evolution of EMS physicians, that kind of role growing nationwide and in Maine, we may find there's a gap between, a standard ED doc taking online medical control versus an EMS physician taking online medical control in certain cases, right? That may be something in the future that we try to set up where you can have it as an option. So anyway, I love that thought. I think the first step would be to assess where are we really at.
Tim, did you just volunteer for a project?
I started to feel that as I started to say that, and then I quickly hit mute on my button. But I would be willing to partner. I'm intimidated to do that on my own, but I do think I would be willing to partner on that. Damn you.
That sounds like a typical Sisyphusian pay project right there.
I think if you wrote a white paper on it first, your project will go a lot smoother.
So I thought the comparison to STEMI was an interesting one, because I think in STEMI, we're kind of highlighting how empowered we've made EMS providers to the point that they can activate cath labs. So I agree. I want providers to call medical control anytime they, need help making a decision. But it doesn't seem like a difficult decision to, start and titrate up pressors if IV boluses aren't working. So that's just my brief thought there.
And regarding the medical control issue, I mean, it's definitely a valid point. I mean, I know probably at most of the centers represented here, the EMS providers have probably pretty quick access to you guys. I mean, I know at my shop there's a dedicated MedCon line. It rings really loud. A doc picks it up or a nurse picks it up and then yells loudly across the room to get a doc. So from that particular point of view, but I think part of it is, even like, so any of the biggest services in the state, right? If you have them working PB, you have one paramedic with a really sick patient, you've got the basic driving, so you have one set of hands in the back. And when you look at the sort of task saturation for these paramedics, it's pretty easy to just say, I'm task saturated. Every time I call MedCon at this particular hospital, they usually hedge or whatever. So I waste, 2 minutes of patient care time giving a report and then ultimately walk away with nothing. So I feel like that there's sort of an not institutional, but a sort of cultural barrier to them even doing this in some cases. I feel like the ones that actually call are the ones that are really far out, like the really rural services who are, 20 minutes from the hospital after they've given their fluid bolus, So I feel like bringing it to the patients in hospitals that are, services that are closer to the hospitals, right? Or even services that are even close to a rural hospital. I mean, we've all had issues through our regions that we've talked about, EMS getting an earful for following a standing order by some doc who is in some St. Elsewhere ER who doesn't agree with the standing order and the protocol. And we've had to deal with this and step in and sort of interject with some education and that kind of stuff. And I just feel like this sort of thing, our patients should be protected from that kind of thing, especially in this situation.
We do have a couple swirling ideas around here, and I'm at fault for that. So let me try to bring us back together. So we've got Dave's original idea, which we need to come back to. We've got my rabbit hole concept that Tim and Seth jumped in with me. Thank you very much, guys. I do like Tim's idea about being as diligent in determining the scope of this problem as possible and being routinized in answering or asking these questions and gaining answers regarding these questions. Perhaps we're not going to solve that today. We're not going to be able to get far on that, but perhaps Tim, you and I could talk offline and come up with some concepts and ideas of how to approach that. As my mind has been thinking about this, I think that we, this strikes me as something that's ripe for survey.
I think we lost you, Matt, or I did anyway.
Yeah, froze.
I was saying this strikes me as an opportunity for questions, talking sessions, surveys, etc. We're not going to be able to answer that today. But let's do this. Let's you and I commit to talking and coming up with some ideas so we can get back to Dave's more pressing questions. Does that sound cool to you, Tim?
Yeah, I'm already thinking of the survey.
And please, anyone else who wants to get into this with us, please join us. So now we need to get back to Dave's point here, which is the value of online medical control here. Any other thoughts amongst the group? Any other considerations? Any other things folks feel strongly about one way or the other?
I think this is, Matt, just listening to your talking about making sure we've optimized fluid control before we squeeze the pipes, right? I think it's two steps. Do we have enough guidance here on the fluids to be given before pressors are considered to empirically feel confident that we're there, right? That we predict with the protocol as it is now. And I think Dave's point is we don't give a volume here, I think is what you're saying. So we could just adopt the sepsis guideline of 30 cc's per kilo as a clean one that's consistent with other houses.
We have that in there right now, though.
Oh, perfect. Sorry, I was jumping. Then I think we're there, and I would say, yeah, let's take away the online medical control.
Well, let me back up. We have that in there under advanced EMT under severe sepsis. So what it reads right now, advanced EMT number 6 for severe sepsis, assess for acute pulmonary edema if present, refer to cardiogenic shock. Adults administer up to 30 milliliter per kilogram fluid bolus, monitor closely during resuscitation. Pediatrics 20 mLs per kg. Immediately reassess if needed, may repeat up to 2 times for a total of 60 mils per kg.
Yeah.
And then after that, get into 7, which is for medical or presumed septic shock. If no response to initial treatment.
Hope she feels better.
I think someone's on, there's a little bit of background noise, if you don't mind muting yourself. Number 7 is for medical or presumed septic shock. If no response to initial treatment, contact medical control to discuss additional fluid bolus versus initiating norepinephrine IV infusion. So that's the way it reads right now, Tim.
Yeah, I'm comfortable with that. I think the proposal here is just to take away the phone icon and allow this to be a paramedic decision without online. Yeah, I'm comfortable with that. I think the proposal here is just to control. I mean, are we in a good enough place for me to propose that as a motion?
Can I talk? Can I add a piece here?
Please, Pete.
I don't know if I'm comfortable with that. And here's why. I know that, the sepsis protocol, and we battle this all the time with our folks in hospital about, the fluid resuscitation in setting of sepsis. But there is a subset of that population that, do you really want to give an end-stage renal disease person 30 cc's of fluid, for fluid resuscitation? And I know that our quality people always say, well, Pete, we can always intubate them. And their outcomes are always better. But I still have consternation, and I don't necessarily know if that is the right way to go. And so my feeling is I personally would rather have a discussion with somebody about, oh yeah, here, it's fine if I decide that Bethany needs 30 cc's per kilo. I know that she can have that, and I'll flood her and she'll pee like crazy. It'll be perfect. But at the same time, you give my dad 30 cc's a kilo, my dad who's 80 million years old and has less hair than I do and has CHF and blah, blah, blah. I don't know if that's the right call. So I guess in some cases, I would like to talk to somebody about that decision, especially if they're 30, 40 minutes away from where I'm coming from. Just my thought. I'd be interested in hearing what other people say. Thank you.
So Pete, is your suggestion then that we put in a caveat under advanced EMT about if concerned for administration of our 60 mLs per kilo fluid bolus and want to discuss early epi administration to consider online medical control?
Yeah, I think it just needs to be a conversation. I mean, if you're giving someone, again, 3 liters of fluid in the field, I want to talk to somebody about that. Just my own opinion, because again, if they come in and all of a sudden they're in fluid CHF and they need an airway because we put them into pulmonary edema because we've fluid resuscitated them really aggressively, which again, probably as probably 85% of the time is probably appropriate. But I think we should have some kind of discussion there before we take it away. Just my thought.
Would it be, in your mind, Pete, reasonable to put maybe an exception sort of thing in there? I totally understand what you're saying. Would it be from a protocolization point of view, and would it be reasonable to say that if a person has a known history of CHF or is on end-stage renal disease and dialysis, that it would be reasonable to call for MedCon on that one? I'm just thinking from a majority point of view, and how do we protocolize this great idea, you know?
Yeah, and I just want to talk about it, talk it through, see what other people think about it, because it's one thing, to resuscitate somebody in front of you versus, the provider, who is traveling, down whatever Route 4 towards me here. I want to have that discussion, and sometimes, and then I think we should just maybe, put a pearl in, or I don't know, before you just use caution in some subsets of patients that, I don't know, again, end stage renal disease, heart failure, whatever we want to add. I just, to say again, but then it's also hard to say, oh, well, then just give them 2 liters. Well, 2 liters in me is not a big deal. 2 liters in, again, I'm just using my dad, and my dad may not be the best, best part. So I don't know what the right answer is. I'd be interested in hearing, what others think. And maybe I'm completely wrong and people say stuff it, and that's okay too.
Pete, I've historically valued the conversation around these patients because as you identify, these are very nuanced patients. We used pressors 210 times in 2018. And while I don't know this definitively, what I know from prior review of our pressor use is that the vast majority of those instances were pressors that we were moving through interfacility transport mechanisms and not pressors that we started. Now, it might be true that what Dave says is we're not using pressors because we don't have a good online medical control system, that there are vulnerabilities in the process of asking, et cetera, et cetera. So there could be their biases, but I tend to agree that these are sick patients, these are nuanced patients, and that having the opportunity to, in my mind, facilitate what I've always thought of as a timeout, so to speak, between the paramedic and the physician to talk about goals, et cetera. In my mind, that's always felt valuable. But I want to, at the same time, be open to patient-centric goals, which are to survive. And how do we capture those 2 things? How do we get those two concepts of the value of this discussion in the right patient, but streamlining care in the equally right patient?
I guess, initially, when this conversation started, I was in the favor of removing the online medical control bit, but I've been thinking about a little more, both what everyone's saying, and then also, I'm just wondering how often this comes up, because it seems to me that for, I don't want to say the vast majority, but I think that for a lot of these patients, they're not going to get their full fluid bolus or even get 1 liter in before they get to the hospital. These are going to be cases of prolonged transport, much more rural type areas. And I'm wondering if the frequency of this occurrence is actually pretty low, and that it's not too onerous and it doesn't, gum up the process too much to have that call to online medical control. I don't see this happening every day on our busier services, because the busier services are by and large going to be in more urban areas where the transport time is much less. So I don't know if you're even going to get to this step. So I'm coming down less on the side of removing the online medical control bit.
Well, I guess sort of to, go ahead.
What if we got more information so we could look to our neighbors in New Hampshire who don't have online medical control as a requirement, right? Because Dave was offering that up. And why can't we reach out to them and say, okay, how many times are you using it? So sort of a little bit of a non-academic request for information. And if they show that they're using it more often, I don't know if that gives us a right or wrong, it's being used right or wrong, but it might answer that question of, is there really a need for this? Do we predict any barriers that are truly being seen? So a release of barriers next door shows more use, because they're kind of they're similar to us in their population and their spread and their areas of rural medicine.
And then I guess one of the other things that we're bringing up too is, so, I mean, I don't propose this, but I guess the question that's coming up is, then do you guys want to put MedCon in for any fluid resuscitation? Because if we're going to take out if we're going to leave the things the way they are, then it's still going to say resuscitate up to 30 cc's per kilo, and nothing will change with that. So the concerns that people are doing about over resuscitating people with fluids, that's not going to really, you know what I mean? That's not going to be changed by the Levofed yay or nay with medical control, that's my thought on it. And with add the utmost respect to, you know, Pete's statement of that not everybody needs the 30 cc's per kilo. I mean, we've all read this in, you know, Annals, Emergency Medicine News. The Medicare sepsis bundle guidelines are, you know, not always in the patient's best interest. And, you know, we're all putting ultrasounds on people's IVCs to determine our initial resuscitation in the ER, but they don't have that tool in the field. So then the question is, then how do we protect our patients? I mean, I wouldn't want to put a medical control option in for resuscitative fluids with hypotension, you know? So for me, I mean, if a person comes into my ER and they're hypotensive and I don't think it's cardiogenic shock and I'm pretty sure it's septic shock, I'm just going to hammer them with fluids for a bit, you know? I mean, there's ESRD that's fluid overloaded versus not. And I mean, I don't know. I mean, that's sort of my thought on it. And I guess if you look back at, you know, what we're concerned about with the medicine Levofed versus the over resuscitation with fluids and stuff, I mean, it is really complicated, you know, but then the question would be, then where do you want them to call MedCon? I mean, do you want advanced EMTs to call MedCon before they resuscitate people? You know?
I am going to make the following proposal. I share all of your concerns, and Pete, I completely agree with where you're coming from. So here's my suggestion for us to continue with a protocolized manner, but also making sure that we're patient-centric. If we look under Advanced EMT 6B, and it says administer up to 30 mLs per kilo of fluid bolus, monitor closely monitor closely during resuscitation. My suggested amendment is that it says something along the lines of, for patients with evidence of fluid overload or at risk for fluid overload, consider consultation with online medical control for earlier pressor initiation. And then that way we can still keep under number 7, that 7A, it says if no response to initial treatment, because now we've given it a possibility for an amendment to our initial treatment and then still have our guidelines for norepi at that point. So they can still start fluid. They're not waiting to hold on fluids to talk with online medical control. They can make a determined decision if the patient looks like they're hypervolemic, or we can even add a PEARL that specifically talks about patients that are at risk for volume overload and pulmonary edema, but still allow those people that don't fit into that caveat and are just our average adult population to go ahead and get the 30 mLs per kilo.
That's reasonable. Yeah, I think that's Thanks.
So Kelly, within this construct, then, so we'll build. I think we need to build that PEARL that you're describing to identify who are the patients who are at risk for fluid overload. What do we do then with online medical control otherwise in norepinephrine? So Dave's proposing that we remove online medical control otherwise in the septic patient. Is that we need to address that directly in your consideration?
Oh man, I totally agree. We need to address that. I was just trying to get us to get to the point that we could all address that. Sorry.
Okay. All right. Maybe I was yeah. I was wondering if that might be all encompassing, but I like your idea of taking it piecemeal. Thank you for that. So if I got this correctly, Kelly, you were saying administer up to 30 milliliters per kilo fluid bolus, period, for patients with evidence of fluid overload or at risk of fluid overload, and we'd have to build this PEARL out. Consider consultation with online medical control for earlier norepinephrine infusion. Does that capture what your statement?
Yeah, thanks, Matt.
I'll second
and
that.
And we still have a little bit of space at the bottom of that page then that we could put the PEARL right under advanced EMT. Or we could add it, there's room on the next page if we want to add it to the rest of the PEARLs for sepsis.
I like putting that stuff in the protocol. I think that's a good thing. So that way it doesn't, you know, if you're sort of heat of the moment, 3 a.m., reminding yourself what the protocol says. I like putting that, I like the idea of building that right into 6B, like you said. and then throw in
Okay,
the pearl down
and then
below.
and then put like an asterisk next to that to refer to the pearl that says patients at risk for volume overload include those with we could put our elderly patients, history of CHF, history of renal failure on hemodialysis. I'm trying to think who else we would be missing there.
That's great. I appreciate it. I have to go to shift. Have a good day, you guys.
Thank you,
Have fun,
Pete.
Pete. Thank you. Yeah, I like that. I think that's very reasonable.
Norm, you left a chat in the you left a note in the chat. Can you do you mind unmuting and kind of explaining that a bit better?
Yeah, what I was saying was I was really in agreement with you, Matt, and with Pete that these patients are nuanced, as you said, they're contextual. And perhaps the best way to do this is, as I think Kelly is going, is to basically share with people that we need to integrate the start of pressors with the volume repletion and the tolerance of this patient given comorbidities to that volume repletion. So some language that gets to that, I think, and Kelly, I think, is getting to it, perhaps would be helpful. Thank you.
Thank you, Norm.
So, so let me just kind of recap what we've got so far. Thank you, Kelly, for this. So Kelly's suggesting under AEMT 6B, administer up to 30 mils per kilo fluid bolus, period, for patients with evidence of fluid overload or at risk of fluid overload. Consider consultation with online medical control for earlier norepinephrine infusion. And then we'd add a pearl that reads something to the effect of patients at risk for fluid overload include but are not limited to elderly patients, those with a history of CHF, and patients on dialysis for renal failure. Like Norm, I like your concept of integrating the initiation of pressors with ensuring adequate volume resuscitation. I think we can find a way to fit that concept into the pearl as well. Kelly, does that capture your intention?
Yep, sounds good to me, Matt.
So you made a motion, and Tim, did you second the motion? I believe I heard you say.
Yeah, I seconded. I just think we would need to be careful with just the term elderly patients. I know that's a draft, Pearl, so we'd want to tie that down or take that out because that's pretty broad. And most of our septic patients are elderly, right? That's the predicted high mortality group to this.
What's your recommendation then, Tim?
I would recommend we just concentrate on CHF and end-stage renal disease.
So Tim, let me make an argument here that if we keep online medical control in for all pressors, but we put this caveat early that says you can call online medical control if you don't think your patient should get 30 mLs per kilo, and we list elderly patients, so you can choose not to call online medical control. You could still give your elderly patient 30 mLs per kilo, but you could also call them early to talk about whether or not you should give them a full 30, and then you're already on the phone with them and you've already had the conversation then about pressors.
Got it. Yeah, no, good argument. I stand corrected. I second it as written. Damn, she's quick.
Because yeah, no, and there absolutely would be a hospital icon in this because the doc absolutely needs to know that the patient on pressors is coming to the ER.
Well, no, we haven't
doesn't
gotten
get thrown in the hall C.
Dave, we haven't gotten that point yet. We're just cleaning up the earlier part around 6B right now, I think. Is that right, Kelly?
Right on.
That's correct. I'm arguing that the pearl should continue to have elderly in anticipation of where we're going next. Because it's not
Got it.
it's not a requirement that you contact online medical control under advanced EMT. We're just giving them an option if they want to not give a full 30 mLs per kilo, they can call online medical control early.
Got it.
Can we define elderly as greater than 675, 75?
Ooh, Tim, now you're making a lot of rules. I like it keeping it vague.
But I'm getting
Right.
happier by the minute, Tim.
Oh man, knocking on the door of 50. I'm totally in agreement with Tim.
I get accused of being disinhibited at home and pre-dementia, so and I'm pretty young.
That sounds like a fast track to a CEO position.
So I think I do think we need to define it. Elderly, I think we got to say either over 65 or over 75. And over 65 would be the broadest in my mind, but I think it's helpful for people to know what we mean.
Do we define elderly anywhere else in our protocols?
Good question.
I will look up elderly in my find function in my little PDF here. Did I spell it right? ELDER. Wait, I should probably put the L in there.
I don't think we can see that part of your screen. Kelly, I'm thinking real quickly, and Kate has as much, if not more, familiarity with the protocols as I do, probably because we act as the editors. I don't know that we have defined elderly. I can think of places where we've had different cutoffs for age, for instance, but I don't know if we've said elderly defined as.
Okay, then that gives us, okay, that's perfect. Then that gives us a lot of flexibility to list it however we want then.
Yeah, I looked at it.
If we're gonna do this, if we're gonna be descript, I might say that we take the word elderly out and just say patients over X age. Is that?
Exactly.
Yeah.
I like that. You won't insult anybody.
Words matter, man. So patients over the age of 75, did we say?
No. Kelly, what was your thought about Tim's question there? 65.
Oh, I don't have a preference. If we're going to use an age cutoff, whatever you guys want to use.
I think 65 probably adds a level of, again, I'm just thoughtful of the nuances that arise in this patient population. I think 65 is an opportunity to be a bit safer here because we've all seen 65-year-olds who look like 95-year-olds. We've seen 95-year-olds who look like 45-year-olds, but I think the former is more common than the latter in many cases.
I'll go with that. I think over 65 is great. It's decisive, but it captures the intent.
Could you just write high mileage?
No.
Because it's not the year, man. It's the mileage, right?
I love that.
So to reorient everyone, and Kelly, correct me if I got any of this wrong. Kelly's recommendation under AEMT 6B in the medical shock protocol is to read as follows: administer up to 30 milliliters per kilogram fluid bolus. For patients with evidence of fluid overload or at risk of fluid overload, consider consultation with online medical control for earlier norepinephrine infusion. And then the pearl that we would add reads: patients at risk for fluid overload include but are not limited to patients over 65 years old, those with a history of CHF, and patients on dialysis for renal failure. And then somehow capturing Norm's language about the integration of pressor initiation with assurance of adequate volume resuscitation.
Or layered upon, either the other word, Matt, is layered upon, integrated with or layered upon fluid repletion.
Yeah.
Your choice. Thank you.
Any other discussion about this motion?
Matt, I've got an issue. My concern with the way that I had initially suggested this edit is that it makes it sound like AEMTs may potentially give pressors. So can we just make sure that the line focuses on smaller fluid, I guess less than 30 cc's per kilo or smaller fluid boluses, or earlier norepi administration by a paramedic, because it's under the AEMT section.
How about if we said consultation with online medical control for resuscitation volume goals or something to that effect?
Yeah, I think that's great. And then we can put the asterisks and in that the pearl up front there saying, you know, smaller, these patients may benefit from smaller volumes and earlier pressor administration. So that we're
like that.
providing education to advanced EMTs, but we're also not suggesting in any way that they should be administering pressors.
That's a nice balance to asterisk it to the pearl.
I'm sorry, I didn't catch that earlier when I suggested it. I apologize.
Tim, are you okay as the second?
Absolutely.
Okay.
So let's just repeat the motion. So my understanding is we're going for advanced EMT. We're going to keep the 30 milliliters per kilo of fluid. And then we're going to add the caveat that populations at risk may not require 30 milliliters per kilo prior to initiation of pressors, like big picture stuff, right? That's where we're going with that?
It will effectively read, administer up to 30 milliliters per kilogram fluid bolus for patients with evidence of fluid overload or at risk of fluid overload, asterisk to a pearl. Consider consultation with online medical control for different resuscitation volume goals.
Got it. Love it.
And then the pearl would be the same with same as I read earlier, but just a little explanation that says these patients may benefit from smaller volumes of resuscitation and earlier initiation of pressors, or earlier layering or earlier integration of pressor support using some of Norm's language. All right, any other discussion about that? Okay, I am a yes. Let's do a roll call vote. I am a yes for that. Kate?
Yes.
Mike?
Yes.
Seth?
Yes.
Yes.
Tim?
Yes.
Dave?
Yes.
Beth?
Yes.
Benji?
Yeah.
Kelly?
Yes.
Bethany?
Yes. Yes.
Pete has had to leave and start a shift. Let me just take a note of that. Claire?
Yes.
And Ray?
Yes.
Great. Dave, are you okay if we take a break at this point in time? Would folks,
You betcha.
Folks okay if we, yeah? Why don't we, it's 11:58 right now. I'm gonna leave the Zoom room running. I might turn off my camera for a second, but why don't we take a break and come back at 12:05? Does that sound good to everyone? All right. Jason, are you still on the line right now?
Yeah, man, I am. What's up?
I'm going to take a photo of that thing I mentioned to you last night and send it to you right now in a PDF form.
Perfect.
Hey, Matt,
Yeah, Bethany.
just had a quick question.
Yeah. I'm sorry. Did you have a question?
Sean Donahue invited me to Grand Rounds on Tuesday.
He and I have been chatting about that.
Probably should put my AirPods in.
So,
Matt,
yeah.
do you want to pause the recording?
Sure.
Yes, sir.
All right, it is 12:05. Do we have our MDPB members back? If you don't mind turning on your camera, that way we can see you if you're back. I guess I can't see everyone right now because we're in this screen share mode. Dave, let's go through our list, I guess. Kate, are you back?
Yes.
Mike, are you back?
Yep.
Seth? All right, let's come back
He's
to Seth.
waving at us. He's there.
I'm back.
Oh, great. Thanks, Seth. Tim, are you back? Your camera's off right now. You're on my screen, but Seth wasn't. Tim? All right, Dave, are you back?
I'm back. Sorry about that.
Oh, there you are. Great. Beth, are you back?
Yes.
Thank you. Benji? Benji, are you back? Kelly's on my screen. Thanks, Kelly. Actually, I guess your camera just went off. Are you indeed back now?
I'm here, Matt. I don't know why. It seems like my camera keeps going in and out.
No, thanks for answering. I see Bethany. Thank you. I think I was scrolling through the list here. I think I saw Claire. You look warmer in a vehicle. And I know Rachel had to step away for a second. She's gonna be a bit. So I think we're still waiting for Tim. Tim, are you back? So I believe we're missing Tim and Rachel. I think everyone else is back. It is now 12:07. Just in the interest of making sure we stick to our agenda, we still have a voting quorum, and hopefully our other members will return ASAP. Dave, do you want to pick it up from there?
Sure. So we left this at, so we voted on the fluids, MedCon.
Now we have to discuss your original point, which was online medical control for norepinephrine or not.
Yeah, and I think, I mean, that's really kind of where it's at now. It's like, so we've talked about the fluids and the other issues that could surround that appropriately. So then the question is, do we want to make Levofed in these situations a standing order or not?
Any discussion about that? Any of our members have any feelings one way or the other?
I guess I'm just a little bit confused. If we had talked about online medical control, then when you say make it a standing order, in what sense, I guess?
So what we did just now was we created pathways for AEMTs and or paramedics to discuss the resuscitation volume goals with online medical control. Dave's original question was, does norepinephrine require online medical control, yes or no? So we addressed some of the issues that Pete had highlighted in reviewing the initial section on volume and whether or not the surviving sepsis ubiquitous 30 milliliters per kilo was the right answer in every individual. Now we're getting back to Dave's original question, which was, does norepinephrine require online medical control?
Got it. I think that I don't think that it needs online medical control as a definition. I think that based on kind of what we did already, I think more than likely you're going to be involving online medical control because you'll be talking about resuscitation and everything else. So I think that's kind of already there. But I think that in terms of streamlining it and if the patient is really, really sick and they need to get it on board right away, I like the idea of that standing order.
I have to agree with that. I think getting a presser up early rather than later is to the advantage of the patient and also to the advantage of the receiving facility and doc who's going to inherit the care of this patient, so that if that presser is already initiated, we can go ahead and titrate upon arrival of the patient, and that I think that is going to save some critical time in resuscitating the patient.
Might I make a suggestion? Under number 7, if we were to choose to get rid of online medical control, if we say for 7A, instead of if no response to initial treatment, we said something along the lines of after appropriate treatment with fluids, referencing the above pearl that we just changed, or the above caveat that we just had changed to say initiate norepi infusion, and that way it's reinforcing that they either have to complete the 30 mLs per kilo or have contacted online medical control to determine that the patient is a candidate for earlier presser use. But taking out contacting online medical control just under number 7.
Just so everyone's on the same page with what Kelly's saying, Dave, can you bring up, or I can do it, I've got it right here if you don't, but can you bring up the current protocol and the way it reads right now so that everyone understands?
Where is it?
If you want,
yes.
I can.
New share.
There you go. Thank you.
Is that up?
Yes, it is. Thank you very much. So Kelly, can you just, with this as the sort of demonstrating, can you just walk through that again?
Yeah, so if you'll take us up just a little bit to the AEMT so we can review what we just said is that patients are either going to get these appropriate fluid boluses as listed, or providers can contact online medical control to give a patient less than this fluid bolus. And then we would go to number 7 and say, right now it says, if no response to initial treatment. Essentially what we're going to say is, if no response to appropriate fluid administration, meaning either that 30 mLs per kilo or what was determined by online medical control, initiate norepi infusion. That way, if they want to start norepi, they can go ahead and we can start doing that early. But if they want to do it before they finish the 30 mLs per kilo, well, they have to contact online medical control because we just referenced that above.
Yeah, I like that a lot. So it's offline medical control. If you've given a fluid bolus, it's failed, start pressors. It's online medical control for the, I think the patient shouldn't get a full fluid bolus, or I want to start concomitant pressors and fluids, and I want to have that discussion.
Exactly.
I agree. Sounds really good. That's a tight wordsmith it.
So Kelly, can you just say that one more time for the purposes of our note keeping and the motion? So if no response to what again? So if no response to initial fluid bolus goals.
Yeah, I want to make sure, I want to take out the word initial because I don't want people to think if they're referencing number 6 above that an initial fluid bolus might be 10 mLs per kilo, and then they're going to start pressors. I want it to say something along the lines of if no response to maybe
I would
like
just call it out. I would just say 30 mLs per kilo.
That was part of the thing, that in order to protocolize standing order levofed, you'd want to specify a clear fluid goal, then a linear initiation of levofed, and then contacting medical control through the hospital icon once it's up there to sort of discuss further stuff. So I think we've captured most of that because, you know, the talk about in the advanced EMT section about the fluids, the special populations, initiating earlier versus later. I think if you put 7 and you just put to if no response to the above, take out the contact medical control, and then just delete the blue part there and then put initiate levofed or norepinephrine for Bethany's sake.
All of our sakes.
For all of our sakes, but specifically for Bethany's, it just makes, we just got to give her a little something today. And
yeah, I like that. If you just say if no response to above treatment, that sounds great because then you're bringing it all back in, and then you can decide if that patient needs 30 mLs per kilo or if they need less, and they've already contacted online medical control at that point.
And then I can't get it to highlight the phone, but this phone is going to become an H because a doc needs to be involved with this. This isn't like a put it in Hall C and we'll get to it when we can, you know, that kind of thing. So you guys all have a Hall C in your ER, and it's usually a suboptimal place to do a resuscitation. I'm assuming that you're getting that one.
I agree with this. I think this is good changes.
So the change here that Kelly's proposing is if no response to above treatment, initiate norepinephrine, et cetera, et cetera, et cetera. And then taking away online medical control, turning that to an H. Does that capture it, Kelly?
Yeah, I think that sounds good.
Are you offering to make that a motion?
I will do just that.
Is there a second for this motion?
I'll second that.
Second.
All right, I think I heard Beth first. Thank you, Beth. Any discussion about this?
I like this. I mean, I know we've discussed this in a couple other places in the protocols, but the pumps themselves frequently get brought up as this barrier to doing things, but then the secondary barrier, or the 1-2 punch of pumps plus phone call, certainly seems to be a reason that people don't go to pressors or some of our other treatments early. And I think by taking away one of those barriers, this is a move in the right direction. I'm excited by this.
Any other comments before we take a roll call vote? I just got a note from Benji that there was a Zoom issue. Benji, are you back with us yet?
Yes, I am back, and I can see the screen now, which I was trying to follow on my paper one, and it's very tricky.
Okay. Any other comments before we take a roll call vote? All right. Why don't we start then? Ray, are you okay with this motion?
Raise a yay.
Raise a yay. Okay, Adam's not here. Claire.
Yes.
Pete had to step away. Bethany,
Yes.
Kelly. Did you
Yes.
make a motion? Thank you. Benji.
Yes.
Beth, you made the second. Thank you.
Yes.
Yes. Okay. Dave.
Yes.
Tim.
Yes.
Seth.
Yes.
Mike.
Yes.
And Kate.
Yes.
I am actually a no, and I think because I am the solitary no, I will explain myself. This is not because I have any concerns amongst our EMS providers, but I am humbled by the nuances of this patient population, and as I mentioned earlier, value the ability to have that conversation with online medical control. I think there is value there. I think we should fix our online medical control system if there are issues with it. But I personally think that patients benefit from your input and your guidance when they are complex. And because this is a very ill patient that we take this step infrequently, I think they would fall into that complex category. So for those reasons, I vote no. But your voice passes as a positive because everyone else voted yes. So
Can I make a suggestion?
who's that? I'm sorry.
It's Kate.
Oh, Kate, yes.
That when this goes into place, that we do pretty diligent QI at the regional levels to look for any trends with a change like this.
And would it be wise to capture Matt's sentiments in a pearl, maybe at the top? Because I mean, it's all true. I think the idea that we're allowing them to initiate this treatment doesn't take away from their complexity or the benefit of medical control. I mean, do you think that's a reasonable plan too? Not that I'm, you know me, I'm not always the one that wants to bulk up the protocols, but I think it's a good thing to put out there.
What do folks think about that suggestion?
I think that's a fantastic suggestion. I think that you're exactly right, Matt, that these patients are very, very sick. And that's part of the reason that I like the idea of trying to start them on norepi earlier is if it's an issue of not wanting to call, I don't want the patient to not necessarily be treated. But you're right, they're very, very sick, and we need to be very careful about how we resuscitate them and mindful of this. My hope also is if we have some earlier norepi administration, that might also clue the hospital into how sick that patient is when they arrive. If for no other reason than norepi alone should not be put into our back hallway or our hallway C. I would also like to suggest if we're going to be adding to the pearls for these patients, also a reminder either within the protocol or in the pearl that it should be through a large bore IV.
I'll play around with this language and include Kelly's comment about large bore IV for norepinephrine, and if folks are okay with that, bring it back to the group for consideration. Does that sound okay?
All right.
I didn't see anyone say that they were okay with that plan. Does that plan sound all right with everyone? I see Bethany's fingers up. I see Kelly up. I see Kate nodding her head. I can't see everyone else on the screen because we're in this.
Yes.
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 Okay.
Yes.
All right. Anyone opposed to that idea?
No, I think it's fine. Ideally, it's safer to have a large bore IV, but we're also in a patient population where any IV is. So I think it's like if available, right? But I think you can bring it back and we can talk about it.
All right, great. Thank you, Dave.
Part of our formulary thing that we're working on a side will probably include tips like that on administration. So making sure of a patent IV and stuff. So it'll follow there.
Oh, you guys don't like the 22 and the pinky trick? Sorry, bad joke. So then my next one, last for gold here, is the code sepsis call itself. Just putting this out there. So if you go back to, I will reshare this part of my screen. Hold on for a second. So can everybody see this one? So medical shock. So when you started the medical shock protocol on the top of page 70, sort of rattles off the identification of possible sepsis. And then basic EMT, it says, attempt to identify the cause, manage the OA as appropriate, request ALS if available, and then do a blood sugar. Wait, where'd that go? What did I do? Sorry. Oh, here we go.
Well, yeah.
So basically the bottom line is, if the basic EMT can't get ALS, do we want them to not notify the receiving hospital that the patient has a code sepsis if they meet all of the above criteria? All of these, or if they meet these, any two, you know what I mean? If they meet the criteria for sepsis and there's no ALS available, I would love it if the EMT would call a code sepsis and say, there's nobody here helping us. This patient's going to be wicked sick when they get there. Though it would probably be picked up in the vital signs if the basic EMT describes any of these criteria there. I just think throwing that extra code sepsis demarcation in there and then allowing them to check that at MEFRS that a code sepsis is called would both help us receive the notification quicker and QA it a little bit better.
So Dave, I think you bring up a really, really interesting point. I think it's a really valuable thing to tease out. I want to just be sensitive to teasing out this idea without necessarily suggesting or diminishing the potential role of AEMTs, or for that matter, paramedics, just to initiate therapies so much sooner in this population. Do you have a way we could try to meet both those goals, i.e., identify the value of the EMT scope and identifying sepsis and alerting the hospital if ALS is absolutely not available, but then at the same time highlighting the value of EMS as far as resuscitating the patient? Those are the two, I think, competing things in my mind that we can probably thread that needle. But do you have a proposed language that you offer to do that?
I guess maybe would it be okay to put notify the receiving hospital that the patient has a code sepsis? Do you want to put it in like a second time up here and keep it down here too? Or just moving this up the stream, because it would keep all the rest of it downstream the same. At least that was my intention anyway. I don't know if that makes sense, or if there's a better way to say that from a wordsmithing point of view.
So taking 6C and pushing it up to be number 4, is that your thought?
Yeah, because then I think it would put it all in the same place, but it would empower the EMT to call the code sepsis while simultaneously activating ALS. If ALS was not available, I just don't want the patient to necessarily get overlooked, you know? And I don't think this is going to happen very often, but on the rare occasion that it does, just a thought out there. I mean, feel free to leave it the way it is if you'd like.
So what do folks think? I think Dave's goal here is very important, which is to recognize the EMT's ability to identify sepsis and to ensure adequate communication with the hospital. Does doing it this way also still value the role of the AEMT and paramedic and the in-field pre-hospital resuscitation of potential septic patients?
I'm fine with it. I will say in my time, I've not seen a huge impact. I'm not sure that I often hear code sepsis called, you know. I think that a lot of times it comes through with the vital signs report anyways. So I don't see a huge impact from it, but I don't see any negatives to it. So I think it's fine.
I mean, in my shop, we built in a specific, I mean, if at our front end, if somebody walks in the door and they meet sepsis criteria, the triage nurse or the front end nurse calls a code sepsis. If EMS calls a code sepsis, we pull out the same worksheet, put the patient in a bed, and just sort of swarm them quick with a really quick, provider low flyby at the pit stop. So that sort of helps us kind of identify a sicker patient, and maybe takes out that lag of, vital sign interpretation on a busy day. I mean, like you said, it's if you're getting a radio report that says the patient's febrile, is tachycardic, and has, or whatever, any of these criteria are up here, obviously the person taking the radio report's gonna probably get the sense that something's going on, but I don't know if, like I said, I don't know how much it would actually help, but.
Dave, I think there is it is a bit of an education push for the EMT level, right? Because, and I think there is some cost to that to consider. And the way we do even our traumas is we have EMS present, and then it's the nurse receiving the information that calls for us a trauma, a code trauma, or code 11 we call it. So we kind of keep in a little filter internally. We still encourage them to call it, but it's really on the person receiving the call to make the decision. So I just think I'm hesitant to add, if we're on the fence on something like this, if we gave it to the EMT level, that would be a lot of people to get a bit more intensive education, which is not free, right? As far as how long our entire protocol update is. So I would say, I don't know if I feel that it's worth that cost personally, just with that education cost. Because the information is still coming through when they give vitals and story.
So Tim, does that, we've had conversations about really ensuring that we're doing our best to maximize the EMT scope of practice. This has been in the protocols. I believe this is the this is the third. So this has been in the protocol for the last 2 cycles. Do you think it is as much of a education push for our EMT colleagues?
I don't know how much, but I'm just thinking a cumulative push. We're already pushing CPAP and NEBS. There's a lot coming down the pike here, and I don't think making this decision makes or breaks whether the information comes across, right? You give the vitals, you give the story. So I'm just trying to put a little bit of a drag on it. And I agree with you though, expanding the scope of the EMT is absolutely the mission of this protocol update. And we want to build the system around them. So it's a great counter argument. I just personally.
And let me just. What we know about our emergency care system is that from the point of initial contact, which you could say is EMD, from the point of initial contact, the only way to get medications on board within an hour is through our EMS system, right? We know that through our pain medication literature. We know that through our asthma literature with steroids, for instance. There are lots of examples of the fact that EMS is the most rapid fashion to get medications or therapies engaged. In this patient, the most essential initial therapy is resuscitation, right? So antibiotics and even source control fall beyond resuscitation. So what Dave's scripted out here is that there's that small group of folks, that potential group of folks who don't have ALS on scene and can't get ALS on scene. And in that situation where we say earlier in the protocols, the hospital is your ALS resource. So in some ways, if we thread this needle to say, request ALS if available, period. ALS is essential in initiating first resuscitative efforts and should be employed whenever possible. If ALS is not available, contact the hospital that this is a code sepsis patient or something to that ilk. That gets the hospital stood up to be prepared for the patient, just like in your critical trauma patients, in your STEMI patients, your stroke patients, and allows for parallel processing rather than scurrying once the patient gets there. Does that make sense at all in your mind? Does that resonate at all? Do you think there's a value there?
Oh, absolutely. I think I absolutely do. I just don't think it's cost free, right? That's it. I think it's very valuable. I just think that it is education, right? And
No,
I'm
yep.
just trying to raise a pause on all of these, right? Just to make sure. But I think you've got a really sound counter argument to say we're not doing this without thought, without purpose. So
Yeah.
Another
That's
thing
all.
the reason this thing came to my attention was we got a new QA person at Capitol, and she asked me, she said, "Hey, why don't EMTs call code sepsis?" And I'm like, I don't know. That's a really good question. So that's kind of one of the things that happened. That's kind of how it kind of got popped into my head. Is a new pair of eyes took a look at the protocols and said,
Folks, I just realized I need to interject for a second. I'm sorry, I've not been doing better keeping track of time, but we've bumped into the time frame. We're supposed to talk about ET3. We can do one of two things, and I leave it up to you. The first thing we could do is finish this piece of the conversation, which it appears as this is Dave's last scripted piece of the conversation. And then we could just keep our meeting going a little bit longer. The other alternate we could do is pause now, come back to this in January, and make sure that we get to the ET3 stuff right now. We have to kind of do the ET3 things because the CMS is endorsing the initiation of that program imminently, and we need to have an answer for the services who are piloting this with CMS. So I leave it in your hands which way we go. I'm fine doing either one, but I did just recognize the time and the fact that we were supposed to talk about ET3 a little while ago. So what is the group's flavor?
I can't.
My preference is.
Well, go ahead, Ray.
I was saying I can't stay late today.
Okay. Kelly, you were going to speak up too, I think.
Oh, I was gonna say my preference is just finish up. If this is the last thing in yellow, just finish this up and then go to ET3.
The only other thing I have is the naloxone distribution thing, which we can totally talk about next month. This is the last thing about a revision of the ongoing protocols in yellow. So if you guys, I mean, whatever the consensus of the group is, I'm fine either way. If you
Let's
wanted to
finish this. I mean, we're on the verge of a proposal, it sounds like.
I'm good with finishing.
All right, and Ray, if you need to take off, please feel free to do so. I'm sorry that I didn't catch this earlier. I apologize. Maybe in an effort to move us along, I would make the motion that we do kind of what I explained earlier, which is to change number 3 to request ALS intercept if available. If in an effort to initiate resuscitation in the field. If ALS is absolutely not available, contact the hospital to call code sepsis and put a hospital sign right there.
I second.
Could you even simplify that more? Request ALS intercept if available and contact hospital and for code sepsis.
Yeah, we could do that. Dave, what do you think about that?
I guess if they have ALS on the way, I don't know. I don't have a problem with it personally because I think the criteria are pretty clear. I don't think it's going to be a lot of. I don't think it's going to be a big miss. So I'm fine with that either way.
Any other discussion about that?
There was a chat from Norm that said something along the lines of, quote, regardless of level of permitted therapeutic intervention, send an alert to the receiving hospital of a code sepsis should be performed. That makes it a lot more broad.
And I think that what I suggested, it captures that because it just puts the alert, right after they call the ALS. So ALS hopefully is on the way if available, and then they call.
So I've been wordsmithing as we go along. If we take Kate's suggestion, which I'm okay with, it would read request ALS if available and contact receiving hospital to notify the patient is a quote code sepsis. ALS is valuable in these patients and allows initiation of essential therapies, including resuscitation. Any thoughts about that? And Dave, are you okay with that change in the motion?
I'm fine with it.
Any other discussion about this? Okay, let's take a roll call vote then. I'll start. I say I vote yes. Kate?
Yes.
Mike?
Yes.
Seth?
Yes. Yes.
Tim?
Yes.
Dave?
Yes.
Beth?
Yes.
Benji?
Yes.
Kelly?
Oh, yeah.
Oh, that was a very strong endorsement. I appreciate that. Bethany?
Yes.
Claire?
Yes.
And Ray?
Yes.
Thank you all for going through that process. I appreciate it. Dave, thank you for all your work around this. We'll have to come back to the rest of it next time round. If you don't mind, canceling your screen share, thank you. I will bring up the next item for discussion, which I did send to folks late yesterday. I think this deserves in and of itself a little bit of explanation. So for those who haven't been with us as long, CMS is authorizing a process called ET3, or Emergency Triage, Treat, and Transport. The idea that CMS has, born out of a white paper they published, I believe in the 2013 timeframe, although don't quote me on that. I can get that for you if you're interested. CMS recognized that there are a number of complaints that could be managed at, that EMS transports, that could also be managed at sites other than an emergency department. And this is an effort from CMS to explore that. And in the summer of I think it was 2019, you all approved the language at the top of this, this language right here, this idea that we as a state would endorse this services and create a pathway for services to participate in the ET3 program. We started meeting about this in the fall of 19. I believe Tim was part of those initial conversations. Kate was a part of those initial conversations. This was, I think, Sam's introduction to us as a state. He came to our first meeting. And initially, the group that was assembled, which included those I mentioned, plus the services and service leadership who are making up the pilot groups, had envisioned an idea in which we would find a number of complaint sets and build protocols to guide the responding EMS clinician toward an ET3 disposition. And you all actually approved at one point in the early 2020 timeframe a draft version of some of those protocols that Jonathan and I had been working on with that group. And we brought that to you for demonstration, and you guys approved that idea. And then COVID hit. And much of our attention has been spent responding to the pandemic. We were informed in the summer timeframe that CMS had initially postponed the ET3 pilot project. We were informed in the summer that they had decided that it was going to go live, and I believe it's early 2021, January 2021 is when our services locally are planning on this. I think that was a decision they made in council with the services that had applied to and been approved to be ET3 pilot services. Those services felt very comfortable with that time frame. Personally, I've struggled to maintain the bandwidth with all the other pandemic related responses we've had. And in the most recent month or so, we've been wrestling with vaccination, but many thanks to folks, including Sam, Kate, and Jonathan Busco, who helped draft some of this language. We've changed course from the initial plan, which was to create protocols for each of 19 complaints, to this plan, which describes a process that's stepwise intended to get to the same place, which is to, number one, complete a full assessment. Number two, consider the patient's complaints and describe an initial set of complaints that would be eligible for ET3 pathways. Number three, to create a broad group of exclusion criteria. Number four, create a more definite group of exclusion criteria for telemedical interventions, because please remember that the ET3 process accounts for 4 alternate dispositions: 1 to a clinic, 1 to an urgent care, 1 through telemedicine, and a 3rd through a qualified healthcare practitioner on site. And our telemedical partners who are going to be participating advised us that if there are therapies that require hands-on intervention or exam steps that require hands-on intervention, they can't do it through telemedicine. So that's an effort here. Step 5 is an open discussion with the patient gaining their consent for utilization of an ET3 pathway, and this is actually required by CMS. And then step 6 is the final requirement by CMS, which is a discussion with the receiving qualified healthcare practitioner at a clinic, at an urgent care, or telemedically. And that's the final adjudication of whether or not the patient is appropriate for this pathway. This was, Sam and I had some long discussions about doing this. And I think in balance, this is the best way we can really exemplify our interest in the CMS pilot process without creating a more laborious process to develop 20+ additional protocols for your review. I apologize that this came to you last minute yesterday. This, Sam and I have been talking over the last few weeks and really wanted to get our stakeholders involvement in this, since they are so critical to this. We met with them yesterday at 2 p.m. and uniformly the group was excited about this as a process map to consider ET3 eligibility. So this is the next step, which is to bring it to you for consideration and review. Any thoughts, any comments, any considerations after reviewing this?
So a few things. There are definitely patients that I see in the ED who I say, why is this person here? But there are a lot of people who fall into these categories like belly pain and asthma, nausea, who definitely do need to be there. So it makes me nervous, but I also see that it's a pilot program. And so we sort of have to try and see what happens. The one exclusion criteria that I think would make me more comfortable would be age, both lower and upper limits of age, maybe. You know, those are high risk populations, and to not have them going elsewhere seems more appropriate to me personally.
So Ray, does the fact that the patient, including their age, their conditions, the absence of exclusion criteria, does the fact that that patient is discussed deliberately with a qualified healthcare practitioner before engaging into the ET3 program assuage some of those concerns?
I guess for the older patient, for pediatric patient, I think, I mean, I guess, I don't know. Yes, it does help. But I think that a lot of urgent cares aren't necessarily, from a peds perspective, comfortable with kids, and a lot of, emergent kids, and finding that needle in a haystack of that kid who has a bigger issue than they appear on the surface. So if a parent is calling EMS for transport to the hospital, I'm still worried about that patient. I don't know. That's my personal peds opinion.
Any other thoughts?
Well, the parents, they can say, no, thank you, I want to go to the ER.
Yes.
It's all like patient trumps this all the time, right?
Yep.
So, and if the parent already chose 911 over express care, right? We have a built-in safety there.
Recently, I forget when this was, Mark and I had a conversation, and I forget who else was there, about calls for very young patients, like less than a month or less than 3 months, for what would have been potentially like a brew that ultimately didn't get transported to the ED, and I don't know why. And so I think there's conversations ongoing about that, but it just makes me nervous that like in the very young patient, something would be missed.
Ray, I share your concerns for patients of all ages, that if our screeners are the same people that will be receiving the patients, again, we get into the situation of sometimes in some of our urgent cares, we have patients seen by people that don't know what they don't know. That is not by any means across the board. And we have a lot of great clinicians that work in our urgent cares, but the standards are very different than the providers that are working in our emergency department that have a specialty training specifically in emergency care and identification of emergent issues. I love the idea of having a telehealth screener or online medical control, but that's a heavy lift to ask of our providers to do. So then the question becomes, who can do that for us? And maybe the answer is we trial it like this and just make sure that we have 100% QA, QI with really good follow-up. And I can tell you that in implementing a similar program in Rhode Island this last year, we found that there were a large majority of patients that, though they were transported to urgent cares or to their PCP, or we also had a clinic that we worked with that would then become a primary care provider for patients that didn't have primary care providers, that a lot of those patients had bounce backs, or a lot of those patients then still required transport to the emergency department, because it's not something that our clinic, that our providers who work in clinics frequently do, which is over the phone screening of patients to determine if they are appropriate for the urgent care versus coming to the emergency department.
So Kelly, do you think that's true? I mean, our clinics in particular are taking those calls every day. Now, they may not take them well, right? There might be some vulnerabilities in that process, but I do think that there is a lot of conversations, at least at the clinic level, regarding adjudication of who can be seen there versus somewhere else.
I think they take calls all the time to say, should we see you, or do you go to the emergency department? But what they don't take are calls from our EMS providers to have a good understanding of what our field providers can do. And then there's also the fact that a lot of times those clinics are taking, the people that are taking calls at clinics sometimes are our medical assistants or our front end desk staff, and they have a general rule that if the patient has any of these complaints, to go to the emergency department. I just don't think that they are as comfortable with what our in-field providers can do.
Let me offer some further background here, just to script this a bit. So CMS requires that there be a dialogue between let me back up even further. CMS requires that this concept be discussed with the patient, and the patient agree to undergo disposition to an ET3 site. Then CMS requires that the responding EMS clinician discuss directly with a qualified healthcare provider. We've also highlighted that in the protocol itself, and we've additionally could put in definitions for that. That is essentially the physician, the NP, or the PA that is going to see the patient at that site, or it's the NPPA or physician who at that site. And additionally, please remember that this is not any urgent care or clinic during the pilot phases, the EMS agencies actually have MOUs with very specific clinics and urgent cares at this point in time, and have run these, have run these concepts and ideas by them. So the fears of getting an MA or a secretary on the phone who has a uniform stance that any person with pain in the chest go to the ED, that shouldn't occur here. And the individuals who are taking these phone calls should be able to adjudicate their comfort in any given patient. Does that help people understand this at all better?
That makes me feel a lot better, Matt. I did not know that background, having not been present during the discussions earlier this year. So thank you so much for that.
Yeah, I think the other things that help here are that, it's now no longer a provider talking to a parent, it's a provider talking to an EMS provider. So they get objective assessment, vital signs, medical terminology, things that you're not going to get from a parent to help determine best disposition. And recall, as Ray said, we get plenty of patients in the emergency department that we all look at, and regardless of what mode they showed up, we say this patient really doesn't need to be here. There are plenty of other outlets in the medical system for this. This is CMS's first attempt to A, allow that to happen after a 911 call, and B, reimburse for that to happen after a 911 call. Meaning that right now, if an ambulance shows up, assesses you and says, that whatever it is probably not life-threatening, but they're happy to take you to the hospital, and you decline and decide you're going to go to urgent care, there's no billing for that EMS assessment. Whereas now, by taking these steps, talking to the urgent care, doing the assessment, there actually will be some billing opportunities for that.
I think I was just going to say 2 comments. Is that I think one, there is some background to this, and we could always look it up for further reference. But I think the city of Houston had a similar type program that they piloted, and they would go out and their guys had iPads, and they would communicate with a doctor, and they'd do that. Urban populations have a different kind of dynamic with EMS, as I think a lot of us know. So it doesn't quite apply to us, but I think a lot of this is where CMS is coming from. And then 2, my other thought was, in terms of us approving this right now, this doesn't mean that starting tomorrow, EMS is going to start taking patients to urgent cares. What this allows us to do is then have a framework to start putting this into protocols, putting this into implementation, talking to interested EMS agencies, finding clinics that might be interested in pursuing it from there. So I think there's still a lot of work to be done. And I think there's a lot of good concerns being raised, but I don't know that we definitely have to decide all of them right now. I think that as I look at it right now, is that I look at this and I say, this is definitely kind of the way that emergency medicine is going. You see it with paramedicine, community paramedicine, and then ET3 is a similar type outreach. And I think that we could be leaders in this. And I think that would be a really good way for us to take some of our EMS programming. And I think in our rural state, it would be really beneficial as well. So I think that us giving the go-ahead to continue this project and working towards further details is important, but I don't think we need all the details right now.
Yeah, let me respond to that. And I also want to just acknowledge Mark's got his hands up, and Mark, I'll get to you, and I'll also respond to a comment that Norm put in there. So I agree with Benji that there have been lots of examples in urban settings. The Dallas-Fort Worth folks are probably the first to have done this and found cost savings in the millions of dollars by at the level of insurance companies by trying to get the right patient to the right place at the right time. Now, I think CMS's engagement of the main services that are doing this is representation of the fact that they recognize there's an equal potential from a rural standpoint, and that finding the right resources for rural patients is equally important. I would actually add one other thing to the second part that I would add something to the second part of what Benji said, which is that I'll actually frame this even further. This is not for every EMS service in the state. This is for 3 or 4 EMS services in the state that have been approved as pilot programs with CMS. And so while we might get to a day where this is the common practice everywhere, this step we're taking right now is even smaller, and it's just authorizing the CMS pilot project and the limited number of the services that have signed up for that. And also, please know, on top of that, if I didn't mention this, CMS requires 100% quality assurance work on every one of these patients. So there is tremendous visibility of this at the CMS level too. Now, Norm, real quickly before we get to Mark, Norm mentioned that does this, I think he read, the other risk is the more important frequent request for ambulance transport as a substitute for personal vehicles, for transparently minor diagnostic entities leading to greater demand on our EMS staff. In essence, does it legitimize overuse of such a limited resource? That is a really important question. And it's a question that we don't have an answer to yet. That's part of what CMS is looking at, part of what CMS is examining, part of what CMS is interested in. I think there are two ways to consider this, though. There could be instances in which Norm's exactly right, in which this puts our EMS availability at jeopardy. But there could be equal number of instances in which an EMS agency transports to a clinic that's local instead of transporting to a hospital that's distant, and it maintains availability of the EMS agency. So I know that CMS is looking at that. I was privy to a conversation amongst the NASEMSO board and CMS back at the beginning of this. And I know that the availability, overutilization, et cetera, are on CMS's radar to consider watching. So we'll have to see how this plays out. Again, one more reason to consider this in a pilot format.
Thank you. Thank you, Matt.
Yeah. Mark, your hand's been up for a bit.
Thanks, Matt. Just I wanted to say from the pediatric perspective is that, you know, I support this idea and this alternate destination. And I think it's great they're going to have a conversation with a physician or other online medical consult. My concern is that when we look at the 2018 data and we see that overall EMS had a no transport rate of about 10%, thereabouts, for all patients overall. But when we drill down to the patients under age 18, our no transport rate goes up to almost 21%. So we're transporting patients that we see, or not transporting patients that we see less of. And this is, I think, what Dr. Williams was alluding to earlier. And, you know, do we take this to a level where we're going to even further increase our non-transports of pediatric patients? And is there a risk behind that because of that higher percentage and what may be missing? Unfortunately, we don't have any 2019 data from our office yet. So I don't know if that trend continues, but it's something that we're still looking at as a program of whether there was bruises that were missed. And the thing to keep in mind about this ET3 program is that there actually has to be a level where they're just not, where they haven't reached the point of the patients not being transported. They're actually supporting transporting them somewhere else. Whereas 20%, 21% of our patients currently aren't transported at all. So it wouldn't even hit this ET3 level. So it's going to increase those non-transports further in a really vulnerable age group. Thank
Mark,
you.
I would disagree with that. I don't think this, so I agree with you in that I think we have a problem with non-transporting pediatric patients. I don't think ET3 puts us in jeopardy for that. I think if anything, patients who are cared for through the ET3 program might be more apt to be transported to emergency departments. But and I also think that having something like this and highlighting the lower acuity complaints, which might be one of the reasons, might be one rationale that providers invoke when not transporting kids, having an additional pathway is going to be an interesting thing to watch for. I think the issue you raised, though, might be independent of ET3. I don't think ET3 will have much impact over non-transport of peds. I could be wrong there.
Agreed. You're talking about a pretty small number of services that are doing this, but you know, where we see one out of every 5 kids that is seen by EMS, and this isn't canceled call, but one out of every 5 patient contacts with a pediatric patient in Maine isn't transported at all. Will that trend continue, or will this ET3 allow them to decrease that number and get them to a different location, which would be awesome? I'm just worried that it'll go the other way, or could potentially go the other way. So I'm glad there's continuing QI on this, and it'll be something that I would encourage to carefully look at in
Yeah,
that age population.
I appreciate that. And I think, independent of ET3, the fact that 1 out of every 5 children are not transported is problematic in my mind. I'm not certain that there will be any change in that with ET3. I think working on our pediatric no transport rate is important, and watching it in the context and construct of ET3 is essential to make sure that we're not disrupting that further. Again, there are limited services involved in the ET3 pilot project, so it may not be that we see this process now making much of a substantive change, but we will be able to ask those services their experience with pediatrics and drill down specifically with them if we so choose, based on the QI program that's required for CMS.
Agreed. And if this does go through the way you're proposing, and I can help in any way, I'd be happy to.
Great, thank you. I'll just read Ray's comments that she said, I have to run to another meeting. It does make me feel better that there will be a qualified provider, not just a triage nurse or in an office will be involved, and that this will be heavily reviewed. I do worry about the nuances of kiddos, which is my thing, but I also know there are plenty of patients that do not need to be in an ED, so it sounds like it's worth a try.
I think people have brought up excellent points. I think this is how you decide. The only way to answer people's concerns is to push this forward as written. We don't have a better chance to evaluate to see if this is safe for all those hesitancies, right? This is an excellent mechanism to try this on and then look carefully, which it's all set up to be very carefully QA'd and studied. I don't see any downside to going forward with this. I also think there's an added benefit of this. There's cost injury to coming to the ED inappropriately. And this is built to help protect our patients from being charged a bill that was way out of proportion for their needs, right? So I just think, and I mean that by you come to the ED for something you could have been seen at your primary care or at express care for much less cost on you.
And you're not real injury too, right? Like if you come to me for something that you don't need to come to, odds are I'm going to overwork you up because that's what I do in emergency medicine. But also it means that the other patient who is sitting in my waiting room may have delayed care because I'm taking care of somebody who is not emergently ill. Yeah, I mean, there's cost injury here and potential real injury every time somebody gets sent to the emergency room. And it's something that unfortunately our 911 system has always been built around, is there is one destination, and that is we're gonna do that 100% of the time.
Yeah, I agree. This also, the cost injury to the system of US healthcare. So the Health Affairs article back in, I can't remember when this was, like 5+ years ago, that estimated system-wide costs to health insurance companies on inappropriate ED care was in the billions, right? And this is a huge opportunity to investigate that. Like, we're so behind the 8 ball in the US on this. Many other countries are triaging on the phone 911 calls to determine who should go and who shouldn't, right? So I really feel like this is, I think we let this thing go. It's on a tight leash. It's had a tremendous amount of time thinking about it as written. And it has a very sophisticated system of oversight developed around it. So I think we got to have courage just to move forward and let this go as written, and then watch it carefully. It'll report back to us so we can critique it. But this is part of a bigger project, much bigger project than this meeting.
Is there any further discussion, or does someone feel comfortable making a motion at this point in time?
I make a motion to proceed as written.
I second that.
All right, sorry. Dave, you seconded that. Any other discussion?
I was gonna say, I mean, having been in some of the talks when this was first presented a couple of years ago at some of the national meetings about a idea of system redesign. This has been super exciting, something that I think our system has needed for a very long time. And while this is coming to us in the same way as other state pilot projects, to recognize that that's not entirely what this is. This is a national initiative, system redesign that we're rolling out in a small format. And the way that we do that in Maine is via this pilot program technique. But it also means that by doing that, we're going to see, can our infrastructure handle this? What does the infrastructure need to look like? We can maintain the oversight over it, and it very well may be that 10 years from now, all agencies in the state are part of this.
Well said. Any other discussion? Let's take a roll call vote then. I am yes. Kate?
Yes.
Mike?
Yes.
Tim?
Yes.
Oh, sorry, Seth. Sorry, Seth. I'm sorry.
Yes.
Tim?
Still yes.
Dave?
Yes.
Beth, are you still with us? Beth, yes, Beth.
Yes.
Benji?
Yes.
Kelly?
Yes.
Bethany?
Yes.
Pete had to go to work. Claire?
Yes.
And then Adam is not here today, and Ray just had to step away, but we still have a voting quorum and the motion passed. Thank you guys for considering this and for the hearty conversation. I appreciate everyone's caution and everyone's considerations, but at the same time, everyone's interest in kind of seeing this through. I really do appreciate that. We are over our time, and I apologize again for losing track there. We still do need to do our old business. Looking around the room, I see Deb and Joanne. Would you guys, either one of you, mind giving us a ops update if you feel appropriate?
We actually didn't have an ops meeting in the last week or so. We've been pretty much working on, COVID and vaccines and the things that we have been informed about and asked to help with. Deb may have other.
Deb, did you have anything else to add? Thank you, Joanne.
I'd like to give an update on a planning grant that Dr. Collmore mentioned a couple months ago on interfacility transports and the lack of EMS staff we have here in the county. We have completed the grant. It's been submitted on November 13th. It's a $100,000 grant through HRSA. And if we get the grant, the planning process will start July 1st, 2021, run through to June 30th, 2022. This grant will help us to apply for bigger grants, like up to $1 million, to help implement anything that comes out of the planning committee. So I just wanted to mention that.
Thank you, Deb. That's really exciting. If there's anything any of us can do, I'm sure. Personally, I'm excited to help you guys out, and I'm sure the rest of the MDPB will be interested as well.
Thank you.
Chris, any education updates?
Thanks, Matt. Work is underway on the education, the COVID specific, the vaccine specific education. More will be able to be done on that after we get more information on the Moderna vaccine. But right now, I'm working on the vaccination training in general, revisiting some of the material that's been done both in the past Medivax program, as well as updates to that material. I anticipate the first of those courses being out, like Sam said, either later on this week or very early next week. And that's all.
Thank you, Chris. I don't see Jason with us for a community paramedicine update. Mark, do you want to provide any EMSC updates?
Sure, just a couple of things real quick, not to keep everybody. The RFP was released a while back and is due December 22nd. That's for a bid for up to $10,000 by an individual, organization, or group to develop pediatric education. The link is on our website and on the pediatric page as well. So please take a look at it or share with colleagues that might be interested in it. So again, it's due December 22nd. Starting in January of 2021, we're going to be surveying all EMS services in the state, and this is reflected in all EMS services nationally to inquire about pediatric training and skills development that they've done over the past year. We went through NASEMSO and formally requested HRSA to delay this survey. We felt that the accuracy is going to be limited because of a lack of in-person training because of COVID. HRSA acknowledged it, but kept going with the survey. So we think that the survey may be limited in its usefulness, but it will happen in January and February. The only other part is we submitted our updated annual report yesterday to HRSA. So that's in process with the normal flow of reports that we have to do. And that's a fairly large report that was submitted and completed on time for them. That's all I have at this time. Thank you.
Congratulations on that report, Mark. That's awesome news.
Thank you.
Kate, do you want to provide any trauma advisory committee updates?
Right now, we've asked the Trauma Advisory Committee to get back to us with any suggestions to the green section. So far, we've had input from one trauma attending. Continue to reach out to them. We are currently creating bylaws for our committee, defining the membership and working on a trauma plan review. And the current trauma plan can be found online. If you guys are interested, I can forward it to you, but we have a subcommittee where we're looking at that and revising it. Right now, we're on hold with our outreach to some of the smaller hospitals where we do kind of self-assessments and some education just because of COVID.
Tim and Kelly, what it strikes me, the TAC will meet after our next MDPB meeting, and we will likely be in the middle of or beginning our green conversation. But we did talk to them about bringing at least an overview of what we're planning to them in the January meeting, which, if I'm correct, Kate, is the 26th of January. Is that correct? Would one of you be
the fourth,
interested?
Sorry, fourth Tuesday, whatever that is. It sounds about right. I would have to look at the calendar.
Would one of you guys be willing to help out with that?
Yeah, Matt, I'm available on Tuesday, the 26th.
Great. We'll talk more. We've got some more talking to do about green anyway, so we'll do that and coordinate that. Thank you guys both for that. So Chris Azevedo, I keep leaving our Maine heart rescue work up here as an aspirational goal, and my heart breaks every time we don't do much with it. I'm reminded once again that one of these days we've got to get back to that. I miss our conversations in your Jeep on long drives around the protocols with that, and one day we'll have to do that again and make sure we get motion there. That is all for our official agenda. I really appreciate folks for agreeing or offering or spending a little bit of extra time with us. I'm sorry for the time mess up on my part. Unless there is anything else,
Matt, quick question. I'm just looking at the Maine EMS calendar, and it does not show us meeting next Monday at 8. We are still meeting at 8, correct?
Oh, actually, Benji, that's a good point. So next Monday would be, let me just pull up my calendar once again. Next Monday would be the third Monday of the month, which we have not met historically on the third Monday. Would you guys, I forgot to bring this to you guys, should we meet on the third Monday of the month? We will know by that point in time if Moderna's EUA has been approved. I don't have any indication that it won't be approved, but we will be taking, we should expect to see Moderna vaccine shipped by that point in time, if not sooner, which means that there is a possibility some of our agencies might be taking receipt of that. The vaccine information, the playbook, the education will all have had to be done by then. So there are things we could talk about. What does the group think about meeting on that day?
I think it would be helpful too, since we're over 500 cases today, and to kind of see where we're at as a system, and a check-in regarding, how the town halls, will have had a couple town halls by then too. And I know we have 3 on Monday. I part of me also wants to, kind of respect that, but not everybody's going to be on those. So I think it would be worthwhile.
Does everyone else feel the same?
Yeah, I agree. I think we need to huddle. A lot going on leading up there, and that'll be a good touch to see where the other hospitals are. I get a lot out of hearing how the rest of your hospitals are doing. It's a huge benefit. I bring that back to ED leadership at Maine General.
Anyone in opposition to meeting on Monday? All right, Mark, would you mind making that notice on the calendar for us? You've done such a good job with all those updates. That'd be really awesome if you don't mind.
If you refresh your calendar, it's up there now.
Thank you. Anything else? All right, hearing none, is there a motion to adjourn?
I'll make that motion.
A number of you did. I'll take that all in uniform. Thank you all very much. I was thinking to myself that we may not see each other before the holidays, in which case I was going to wish everyone happy holidays. There's a chance that we'll see some of each other on Monday, but in case someone can't make that meeting, please, heartfelt happy holidays to everyone, and look forward to seeing you after that, between Christmas and New Year's. Thank you guys so much for everything. I guess we'll be seeing each other for the town halls too, so lots of opportunities to say hello, and be in touch soon. Take care, everyone.